Good morning, everyone. We are going to officially pass this meeting to our new chair, Dr. Grace Lee, to officially open the ACIP meeting, and then I will go through our welcome slides.
Perfect. Thank you, Dr. Cohn, and welcome everyone to our 10th ACIP meeting for 2021 and our 20th meeting since the start of the COVID-19 pandemic. I wanted to just take a couple of minutes as I chair my first meeting today to again acknowledge our outgoing members, Dr. Hank Bernstein, Dr. Sharon Fry, and Dr. Jose Romero, our former chair of ACIP. We're really grateful for their service and dedication to our committee. And I just want to take a moment to thank our current ACIP members for continuing to support our country on decisions about the use of vaccines, and in particular for your willingness to make decisions in the face of uncertainty and constantly evolving data. I am going to turn it over at this time to Dr. Cohn to launch our welcome slides, and then I will take roll after that. Thank you.
Great. Good morning, everybody, and welcome to the COVID August 13th virtual ACIP meeting. Copies of the slides that are being presented today are available on the ACIP website and available through a share link file for ACIP voting, liaison, and ex officio meetings. Next slide. These are the same notes. I believe you've probably seen these now almost 20 times about how to work the Zoom call. So virtually raise your hand. And during the discussion, Dr. Lee will take questions first from the voting ACIP members and then from ex officio members and liaison representatives. The videos will be disabled until the vote, and then the ACIP voting members will turn on their video during the vote. Next slide. ACIP is at its heart a public body, and engagement with the public and transparency in our processes is vital to our committee's work. For this meeting, we'll be holding a public comment period prior to the vote at about 12:15, 12:30 this afternoon. This will be the oral public comment period. In addition, there is a docket for written public comment available at www.regulations.gov. The docket ID for this meeting is CDC-2021-0084. The ACIP members have received this meeting docket and are reviewing public comments. Next slide. Members of the ACIP agreed to forego participation in certain activities related to vaccines during their tenure on the committee. We have issued some limited conflicts of interest waivers for members of ACIP who conduct clinical trials or serve on data safety monitoring boards. In this situation, ACIP members will be asked to, are prohibited from participating in committee votes on issues related to those vaccines. In addition, they are prohibited from voting on any other vote that involves a company, the company that the clinical trial or DSMB board is part of. Next slide. I want to alert you to some upcoming ACIP meetings. The first is scheduled at this time for August 24th, 2021. This will be a follow-up meeting to this meeting and will be related to COVID-19 vaccines only. We are having an additional meeting to catch up on our non-COVID related activities. The FRN should be available for this meeting soon. This will be September 29th and 30th of this year, so please be on the lookout for the agenda for that meeting. In addition, we will be having our regularly scheduled October 20th to 21st meeting on non-COVID vaccine related issues. There will always and likely be additional COVID vaccine meetings, so please continue to check the ACIP website. We do try to update the ACIP website as soon as possible. Next slide. Before Dr. Lee takes roll, I do just want to make a couple of comments about the committee today. We have, as Dr. Lee mentioned, we have said goodbye to 3 of our outgoing members. We have new members that have been approved and have accepted, but we're continuing to onboard them to be officially members and to be able to participate in these meetings. They're listening on the line today, but we welcome them and will announce them as soon as they are on board. So we will have fewer ACIP members than typical at this meeting, but we still have well above our quorum. So our quorum for this committee is 8, and we should have 11 members participating today. So Dr. Lee, I will hand it over to you to start taking roll, and remember, when the ACIP members announce themselves, please announce if you have any conflicts of interest. Dr. Lee?
Thank you. We are excited to have the opportunity at the next meeting, hopefully, to welcome our new ACIP members, as Dr. Cohn mentioned. And I also just wanted to take a quick moment to thank our ACIP Secretariat, Drs. Amanda Cohn, Jessica McNeil, and Stephanie Thomas, for all their work in setting us up for this meeting today and just making sure that things run smoothly for all of ACIP. So I'll now take roll call, starting with the ACIP members and then the ex officio members and liaisons. For the ACIP members, I'm going to ask that you state your name, your affiliation, and whether you have any conflicts of interest. And then for the ex officio and liaisons, I'll just announce your organization name, and then please indicate if you're present and your first and last name. So we will start with Dr. Alt.
My name is Kevin Alt, and I'm an obstetrician gynecologist at the University of Kansas in Kansas City, Kansas, and I have no conflicts of interest.
Thank you. Ms. Lynn Bata.
Good morning. This is Lynn Bata. I am a public health nurse with the Minnesota Department of Health, providing clinical consultation to the immunization program, and I have no conflicts.
Thank you. Dr. Chen.
Wilbur Chen, adult infectious disease physician, professor of medicine at the University of Maryland School of Medicine, and I have no conflicts.
Thank you. Dr. Daly.
Good morning. Matt Daly, Senior Investigator, Institute for Health Research, Kaiser Permanente, Colorado, Associate Professor, Pediatrics, University of Colorado School of Medicine. I have no conflicts.
Thank you. Dr. Cotton.
Good morning. Camille Cotton. I am the Clinical Director of Transplant and Immunocompromised Host Infectious Disease at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have no conflicts.
Thank you. Dr. Long.
Good morning, Sarah Long. I'm a pediatric infectious disease doctor and professor of pediatrics at Drexel University College of Medicine in Philadelphia, and I have no conflict.
Thank you, Dr. Long. Ms. McNally.
Good morning. Veronica McNally, President of the Brainy Strong Foundation, located in Michigan, and I have no conflicts.
Thank you. Dr. Paling.
Good morning. This is Kathy Paling. I'm a general pediatrician and professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine. I have no conflicts.
Thank you. Dr. Sanchez.
Dr. Lee, Dr. Sanchez is going to be late to this meeting. He will be, he'll announce himself when he joins.
Yes, thank you. Please let me know when he is able to join, and we'll call on him then. Dr. Talbot.
Good morning. I'm Kip Talbot. I'm an associate professor of medicine. I'm an adult infectious disease physician, and I have no conflicts.
Thank you. And I believe I'm the last one on the list. So Grace Lee, Associate CMO at Stanford Children's Health, Professor of Pediatrics and Infectious Diseases at Stanford University School of Medicine, and I have no conflicts. With that, we will move on to our ex officio members and liaisons. And again, I'll state the name of the organization. If you could please indicate if you're present and your first and last name. Centers for Disease Control and Prevention.
Good morning. This is Melinda Horton.
Thank you. Centers for Medicare and Medicaid Services.
Good morning. This is Mary Beth Hance.
Thank you. Food and Drug Administration.
Good morning. This is Doran Fink, and I'm also pleased to announce that Peter Marks, Director of Center for Biologics Evaluation and Research, is here representing FDA as well.
Thank you, Dr. Fink and Dr. Marks. Health Resources and Service Administration.
Good morning. This is Mary Rubin.
Thank you. Indian Health Service.
Good morning. Thomas Weiser for Indian Health Service.
Great. National Institutes of Health.
Good morning, John Bible, National Institute of Allergy and Infectious Disease, NIH.
Thank you. Office of Infectious Disease and HIV/AIDS Policy.
Good morning. This is David Kim.
Morning. We'll move on to our liaison representatives, the American Academy of Family Physicians.
Good morning, Pamela Rockwell, Associate Professor of Family Medicine, University of Michigan Medical School, AAFP.
Thank you. American Academy of Pediatrics.
Good morning, Bonnie Maldonado, Professor of Global Health and Infectious Diseases, Stanford University, and Chair of the Committee on Infectious Diseases for the American Academy of Pediatrics.
Thank you. And do we have our colleague on from the American Academy of Pediatrics Red Book today?
Yes, David Kimberlin, editor of the AAP Red Book.
Thank you. American Academy of Physician Assistants.
Good morning, Marie-Michelle Léger, Director of Clinical Education, American Academy of PAs.
Thank you. American College Health Association.
Good morning, Sharon McMullen, Cornell University, co-chair of ACHA's Vaccine Preventable Diseases Committee.
Thank you. American College of Nurse Midwives.
Present, Pamela Meharry.
Thank you. American College of Obstetrics and Gynecologists.
Hi, this is Linda Eckert, and I'm with ACOG. Thank you.
Thank you. American College of Physicians.
Good morning, Jason Goldman, General Internal Medicine in Coral Springs, Florida, Affiliate Associate Professor at Florida Atlantic University, representing the American College of Physicians. Pleasure to be here and congratulations on your chairmanship.
Thank you. American Geriatric Society.
Educator for AGS.
Thank you. Americans Health Insurance Plans.
This is Bob Gluckman, Chief Medical Officer, Providence Health Plans, Portland, Oregon. Thank you.
Thank you. American Immunization Registry Association.
Good morning, Rebecca Coyle is here representing ERA.
Perfect, thank you. American Medical Association.
Sandra Freihofer, practicing general internist in Atlanta, adjunct associate professor of medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Good morning, Chad Riddle, representing the ANA.
Thank you. American Osteopathic Association.
Dan Grau, good morning to you. Thank you.
Thank you. American Pharmacists Association.
Good morning, this is Steve Foster.
Thank you. Association of Immunization Managers.
Hi, this is Molly Howell, Immunization Director for the North Dakota Department of Health, representing AIM.
Thank you. Association for Prevention, Teaching, and Research.
This is Paul McKinney, University of Louisville School of Public Health and Information Sciences.
Thank you. Association of State and Territorial Health Officials.
Good morning, Dr. Lee. This is Neeraj Shah. I'm the Director of the State of Maine Center for Disease Control and the President of ASTA.
Thanks, Dr. Shah. Biotechnology Innovation Organization.
Good morning. Phyllis Arthur, representing BIO.
Morning. Council of State and Territorial Epidemiologists.
Christine Hahn, present.
Thank you. Canadian National Advisory Committee on Immunization.
Good morning, Shelley Gates.
Morning. Infectious Diseases Society of America.
Carol Baker, good morning.
Morning. International Society for Travel Medicine.
Good morning, Elizabeth Barnett for the ISTM.
Thank you. National Association of County and City Health Officials.
Good morning, this is Matt Zahn representing NACHO.
Thank you. National Association of Pediatric Nurse Practitioners.
Good morning, Patsy Stinchfield representing NAPNAP.
Thank you. National Foundation for Infectious Diseases. National Foundation for Infectious Diseases. I can see you.
Oh, now I'm unmuted.
Thank you.
Thanks, Grace. This is Bill Schaffner. I'm a professor of preventive medicine and infectious diseases at Vanderbilt and medical director of the National Foundation for Infectious Diseases. Thank you.
Thank you. National Medical Association.
Virginia Kane is substituting for Dr. Whitley Williams. Are you there, Ms. Kane? Dr. Kane? She's not here quite yet. We can move on, Dr. Lee.
Thank you. Pediatric Infectious Diseases Society.
Good morning, Dr. Lee. Sean O'Leary, representing the Pediatric Infectious Diseases Society.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good morning, Corey Robertson, President.
Morning. Society for Adolescent Health and Medicine.
Good morning. It's Amy Middleman representing SAM.
Morning. And Society for Healthcare Epidemiology of America.
Good morning. This is Marcy Dries, Chief Infection Prevention Officer at Christiana Care, representing SHE.
Thank you. And with that, any individuals or organizations that I've missed, Dr. Cohn?
Yes, National Medical Association, Dr. Virginia Kane.
Thank you. Thank you for joining us today. Terrific. Okay, and with that, I think we can move on to the next section of the agenda. Actually, before we start, just a few announcements. Dr. Cohn, you can jump in if I get the order a little bit off today. But during today's meeting, I'm going to invite individuals to contribute to the discussion. Please raise your hands electronically, as mentioned, and I'm going to call on ACIP members first, followed by our ex officio members and liaisons. We are going to try a new approach that if you wish to respond to a particular comment or question, for the ACIP members, please indicate you'd like to respond via the thumbs up button, and I will try and call on you to respond to the issue being discussed. We're always evolving and continually improving. So, but before we get started, I believe I'd like to turn it over to Dr. Cohn and our colleagues from the FDA to make a statement perhaps about the ongoing decisions that were made recently.
Dr. Finker, Dr. Marks, do y'all want to provide us with the announcement of the EUA that was approved last night?
Sure. This is Peter Marks. I can do that if you'd like. So thanks very much. So as everyone's aware, the immunocompromised are a heterogeneous group in their ability to respond to the available COVID-19 vaccines. Some have a relatively modest immune repairment. Others may either not respond or respond poorly to the existing COVID-19 vaccines. Those are individuals such as those who have received solid organ transplants or who are on other medications that are typically used for solid organ transplants. And after reviewing recent studies, including two different studies, one for the Pfizer-BioNTech vaccine and the other for the Moderna vaccine, both of which have now appeared in letter format in the New England Journal of Medicine. We decided to amend the emergency use authorization to allow for a third dose of COVID-19 vaccine to be administered to individuals at least 12 years of age for the Pfizer-BioNTech vaccine or 18 years of age for the Moderna vaccine who had undergone solid organ transplantation or who were diagnosed with conditions that are considered to have an equivalent level of immunocompromise. We've caveated that with the fact that the administration of these third doses appears to be only moderately effective in increasing antibody titers, so patients should be counseled to maintain physical precautions to help prevent COVID-19, and close contacts of immunocompromised persons should be vaccinated as appropriate for their health status. We will continue to evaluate data as it becomes available, but for now, we have done this for these two vaccines. Over.
Thank you, Dr. Marks. We really appreciate you setting the context for today's meeting. So that's really helpful. All right. In today's first COVID-19 session, we will have Dr. Matt Daly provide an introduction. Dr. Kathleen Dooling will present on the evidence to recommendations framework on additional doses of mRNA COVID-19 vaccines, and Dr. Neela Goswami will present on clinical considerations for use of additional doses of mRNA COVID-19 vaccines. And with that, I think I can turn it over to Dr. Daly for the introduction.
Good morning. So I'll provide a few introductory slides on behalf of the ACIP COVID-19 Vaccines Work Group. Next slide, please. This is a graph that we've seen and presented at several prior meetings. The y-axis I'll highlight is that cases, daily cases in hundreds of thousands, with time on the x-axis. And as you can see, since July 1st, there's been a 700% increase in the 7-day moving average for COVID-19 cases in the United States. Next slide, please. So to update the ACIP on COVID-19 vaccines work group activities for the last 2 months, we've been meeting at least weekly. And the topics covered at those meetings have included the following. We have reviewed vaccines with respect to SARS-CoV-2 variants. We've reviewed and discussed updates on myocarditis following vaccination. In addition, we reviewed in detail the evidence to recommendations framework for additional doses of mRNA vaccines for immunocompromised individuals, and we'll hear more about that today. We have also discussed a number of clinical considerations related to these individuals as well as other issues. And additionally, we've talked about considerations for booster doses of COVID-19 vaccines in the broader, more general population. Next slide, please. So for today's ACIP meeting, we will specifically discuss additional doses of mRNA COVID-19 vaccines as part of a primary series in immunocompromised individuals. And then in addition, we will also discuss considerations for booster doses of COVID-19 vaccines in the general population. Next slide, please. So here's the detailed agenda. As Dr. Lee mentioned, we will start with a presentation by Dr. Kathleen Dooling, which is going to present the evidence to recommendations framework, additional doses of mRNA COVID-19 vaccines as part of a primary series for immunocompromised individuals or people. She'll be followed by a presentation by Dr. Neela Goswami, who will discuss clinical considerations for use of additional doses of mRNA COVID-19 vaccines as part of a primary vaccination series for immunocompromised people. After Dr. Goswami's presentation, we'll have a public comment, after which we will have a vote. And then after the vote, we'll have 2 additional presentations. The first by Dr. Heather Scobie, which will be an update on emerging SARS-CoV-2 variants and COVID-19 vaccines, followed by Dr. Sarah Oliver, who will present on considerations for booster doses of COVID-19 vaccines, followed by a ACIP discussion. Next slide, please. So I'd like to thank all of the COVID-19 vaccines work group members, ACIP members, ex officio members, liaisons, and consultants, and in particular, the CDC leads, Dr. Sarah Oliver and Dr. Kathleen Dooling. Next slide, please. As well as a number of CDC participants who've worked tremendously hard and made outstanding contributions to the entire process. Next slide, please. Thank you very much. I'll turn this back to you, Dr. Lee.
Thanks, Dr. Daly. And with that, I think we'll proceed to Dr. Kathleen Dooling to discuss the evidence to recommendations framework. Thank you.
Thank you, Dr. Lee. The topic for this presentation will be an additional dose of mRNA COVID-19 vaccine following a primary series in immunocompromised people. Next slide. Before getting into the evidence to recommendation framework, I'd like to reference the regulatory allowance upon which we're proceeding today, which was introduced by Dr. Marks. Last night, August 12th, the FDA authorized an additional vaccine dose for certain immunocompromised individuals. It should be noted that the amendment only applies to immunocompromised people. Other fully vaccinated individuals do not need an additional dose right now. The amendment applies to Pfizer-BioNTech COVID-19 vaccine ages 12 and older and Moderna COVID-19 vaccine ages 18 and older. Data are insufficient for the EUA amendment for an additional dose. Due to insufficient data, the EUA amendment for an additional dose does not apply to Janssen COVID-19 vaccine or individuals who received Janssen COVID-19 as a primary series. CDC and FDA are actively engaged to ensure that immunocompromised recipients of Janssen COVID-19 vaccine have optimal vaccine protection. Next slide. So as sanctioned by the ACIP, the evidence, next slide. The evidence to recommendation framework allows us to describe the evidence to inform ACIP recommendations in a transparent manner. Next slide. So this is our policy question for today. Should ACIP recommend vaccination with an additional dose of either Pfizer-BioNTech or Moderna COVID-19 vaccine, otherwise known as mRNA vaccines, following a primary series in immunocompromised people under an emergency use authorization? Next slide. This discussion will be focused on the immunocompromised population, and by that we mean people with medical conditions or people receiving treatments that are associated with moderate to severe immune compromise. So that includes active or recent treatment for a solid tumor or hematologic malignancy, receipt of solid organ or recent hematopoietic stem cell transplants, severe primary immunodeficiency, advanced or untreated HIV infection, active treatment with high-dose corticosteroids, alkylating agents, metabolites, tumor necrosis blockers, and other biologic agents that are immunosuppressive or immunomodulatory. And finally, there are chronic medical conditions such as asplenia and chronic renal disease that may be associated with varying degrees of immune deficit. Next slide. So the intervention that we are focused on is an additional dose of mRNA COVID-19 vaccine. An additional dose of Pfizer-BioNTech COVID-19 vaccine or Moderna COVID-19 vaccine, both in people 18 years of age and older, after an initial 2-dose primary series of mRNA COVID-19 vaccine in immunocompromised people. Please note that the work group interpretations that follow were based on consideration of people 18 years of age and older for both vaccines. However, the FDA emergency use authorization amendment provides allowance for the use of an additional dose of Pfizer vaccine in adolescents 12 to 17 years old. We look forward to ACIP discussion on the optimal age range. Next slide. Sorry, if you can go back a slide. I advanced too quickly. So attempts should be made to match the additional dose type of the mRNA primary series. However, if that is not feasible, a heterologous additional dose is permitted. The additional dose of mRNA COVID-19 vaccine should be administered at least 28 days after completion of the primary mRNA COVID-19 vaccine series. Next slide. So before proceeding with the ETR, I'd like to reiterate that any recommendation for an additional dose would not supplant the importance of infection prevention measures. Immunocompromised people should continue to wear a mask, stay 6 feet apart from others they don't live with, and avoid crowds and poorly ventilated indoor spaces until advised otherwise by their healthcare provider. And importantly, close contacts of immunocompromised people are strongly encouraged to be vaccinated against COVID-19. Next slide. The evidence to recommendation framework domains and central questions are listed here. As we move through each domain, next slide, The public health problem refers to COVID-19 among immunocompromised people, and the intervention refers to an additional dose of mRNA COVID-19 vaccine in immunocompromised people who have already received a primary series of an mRNA COVID vaccine. Next slide. First, a description of the public health problem. Next slide. COVID-19 cases have been increasing since early July. As of August 9th, there have been over 35 million COVID-19 cases reported to CDC, with the most recent 7-day averages of over 100,000 cases per day. Next slide. Hospitalization rates, too, have been increasing since early July. Next slide. Deaths have also been increasing. The current 7-day moving average is over 600 deaths per day from COVID-19. Next slide. According to one national survey, immunocompromised people comprise approximately 2.7% of the U.S. adult population, or approximately 7 million adults. Immunocompromised people are more likely to get severely ill from COVID-19. They are at higher risk for prolonged SARS-CoV-2 infection and shedding, and viral evolution during the infection and treatment, particularly amongst hospitalized patients. They have a lower antibody neutralization titers to SARS-CoV-2 variants compared to non-immunocompromised people, and they are more likely to transmit SARS-CoV-2 to household contacts. Next slide. Immunocompromised people are more likely to have breakthrough infection. In small studies of hospitalized breakthrough cases, 40 to 44% were deemed to be immunocompromised. Several observational studies have shown lower vaccine effectiveness, with VE estimates ranging from 59 to 72% among immunocompromised versus 90 to 94% among non-immunocompromised people after 2 doses of mRNA vaccine. Next slide. This graph is one we've presented before, and it's been updated since, but it shows the percentage of antibody response after 2 mRNA vaccine doses by different types of immunocompromising condition. Studies among people with cancer are shown in blue, with hematologic cancers shown in darker blue. The proportion with antibody response ranged from 45% to 95%, with lower responses seen among people with hematologic cancers. Studies of people on hemodialysis are shown in green and ranged from 71% to 98% response following 2 doses. Studies of people with solid organ transplant had the largest deficits in antibody response, ranging from 0 to 79%. Studies of people with treated for autoimmune or inflammatory disorders ranged from 40% to 94% response to an mRNA primary series. By comparison, healthy controls, where they were included in these studies, ranged from 95 to 100% of vaccine response. Almost all studies that assessed response after the first and second doses demonstrated a less robust response after only 1 dose. Next slide. Several countries, including France, UK, Israel, and Germany, are considering or have announced plans for the use of an additional dose in immunocompromised people. Next slide. Based on review of this data, the work group felt that yes, COVID disease among immunocompromised people is of public health importance. Next slide. Moving on to benefits and harms. Next slide. We will aim to answer this question, how substantial are the desirable anticipated effects? Next slide. And how substantial are the anticipated undesirable effects? Next slide. And ultimately, if the desirable effects outweigh the undesirable effects. Next slide. Earlier this week, the first randomized trial of 3rd dose of mRNA vaccine in transplant recipients was published. This study randomized 120 vaccinated people to either a 3rd dose of Moderna vaccine or placebo. The primary outcome was a receptor binding domain antibody level of at least 100 units per mil at 1 month post-dose 3. As you can see from the figures panels A and B, antibodies were higher in recipients of the third dose of Moderna vaccine, with 55% of the vaccine group achieving the endpoint versus only 18% of the placebo group. Encouraging improvements in immune response were also observed for neutralizing antibodies and T cell function. Next slide. This slide shows 5 observational studies, 2 in recipients of solid organ transplants and 3 in patients on hemodialysis. The studies looked at the seropositivity after a second dose of mRNA, which ranged from 20 to 89%, and then a third dose of mRNA was administered. Among those who had no detectable antibody response to the initial mRNA vaccine primary series, 33 to 50% developed an antibody response to a third dose. Next slide. In the Kumar et al. Study of solid organ transplant patients, shown on the previous slide, the proportion of the group who were seropositive increased after each dose, 40% post-dose 2 and 68% 1 month post-dose 3. In addition, as you can see in panel B, the average antibody titer increased after each dose. So even those who were already seropositive experienced increases in their antibody levels. In this study of 99 transplant patients, no serious adverse events were reported after administration of the third dose, and no acute rejection episodes occurred. Next slide. Here we highlight the Epsi et al. Study, which showed the reactogenicity of a third mRNA vaccine in a cohort of patients on hemodialysis. No patients developed side effects that required hospitalization. Symptoms reported were consistent with the previous doses, and the intensity of the symptoms was mostly mild in yellow or moderate in orange, as you can see. Next slide. To summarize the available evidence regarding possible benefits, emerging experimental and observational data in adults suggests that an additional mRNA COVID vaccine in immunocompromised people enhances antibody response and increases the proportion who respond to COVID-19 vaccine. No efficacy or effectiveness studies of COVID-19 prevention following a third dose exist. With respect to potential harms, in small studies of an additional dose of mRNA vaccine, no serious adverse events were observed, and reactogenicity of a third dose of mRNA was similar to prior doses. It should be noted that mRNA COVID-19 vaccines are associated with rare but serious adverse events, including anaphylaxis, as well as myocarditis and pericarditis in young adults. The impact of immunocompromising conditions on these rare events is unknown. There are no safety studies published on additional mRNA doses in immunocompromised adolescents. Next slide. The work group felt that the desirable anticipated effects were large. Next slide. And the undesirable anticipated effects were minimal. Next slide. And that the balance favored the intervention, the use of an additional dose of mRNA COVID vaccine in immunocompromised people. Next slide. Moving on to values and acceptability. Next. Here we will try to address how the target population feels about the balance of desirable and undesirable effects. Next. And is there variability in how people value the outcomes? Next. And is an additional dose of mRNA COVID-19 vaccines acceptable to stakeholders? Next slide. First, let's look at the use of additional doses of COVID-19 vaccines in the general U.S. population, a practice that is not currently recommended by ACIP. Approximately 140 million individuals completed a 2-dose primary series of either Moderna or Pfizer BioNTech COVID-19 vaccine. Approximately 1.14 million people, that's less than 1%, received 1 or more additional COVID-19 vaccine doses. Approximately 12 million individuals received a one-dose primary series of Janssen COVID-19 vaccine, and a little over 90,000 of them, also constituting about 1% of this population, received one or more additional doses of COVID-19 vaccines. Next slide, please. Now, to focus in on the immunocompromised population that we're considering here today, we can look to a large study that was conducted among individuals with cancer, autoimmune disease, and other conditions early in the COVID vaccine rollout. At that time, 81% were already vaccinated or intended to become vaccinated. 19% either said that they were unsure, probably wouldn't, or definitely wouldn't receive a COVID-19 vaccine. This was a higher intent to vaccinate than the general adult population. Factors associated with hesitancy among the recipients were younger age, female gender, Black, Pacific Island, or Native American race or ethnicity, and less formal education, anti-vaccine sentiment, and distrust of the media. Next slide. In terms of stated reasons for vaccine refusal among immunocompromised people are many and varied, but across studies, concerns about safety and possible side effects, as well as the discomfort or distrust of vaccines, were common. Next slide. Professional bodies strongly support COVID-19 vaccination and use of an additional dose in immunocompromised populations. In the many letters received from professional associations, whom are listed on this slide, two main points emerged. They encouraged study of the safety and effectiveness and efficacy of an additional dose of COVID-19 vaccine in immunocompromised people, and they supported swift action on the part of ACIP to recommend use of an additional dose of COVID-19 vaccine in immunocompromised people. Please note that the Pediatric Infectious Diseases Society and Children's Oncology Group supported use of an additional dose in immunocompromised adolescents. Next slide. Patient advocacy bodies also expressed strong support of COVID-19 vaccination and study of an additional dose. Specifically, the Leukemia and Lymphoma Society supports providing access to doses of COVID-19 vaccine for supplemental vaccination in immunocompromised patients and urge that these patients have the opportunity to be among the first to receive these additional doses. Next slide. In summary, the available evidence for values is that overall, initial intent to vaccinate is high among immunocompromised populations. Concerns about safety and possible side effects are the main reasons for vaccine hesitancy. Younger age, female gender, racial and ethnic minorities, and less formal education are factors associated with vaccine hesitancy. Strong support for an additional dose was expressed by immunocompromised patients via written and oral comment to ACIP meeting on July 22nd, 2021. Next slide. With regard to acceptability, professionals who provide healthcare to immunocompromised people recognize that their patients are at high risk for severe outcomes from COVID-19 and strongly support a recommendation for an additional dose of COVID vaccine. Societies that advocate for access to the best quality care for patients with immunocompromising conditions support access to an additional dose of COVID-19 vaccine to increase the chances of vaccine protection. Next slide. The work group concluded that the target group felt the desirable effects were large compared to the undesirable effects. Next slide. And that there was probably not important uncertainty or variability. Next slide. The work group felt that yes, an additional dose of mRNA COVID vaccine for immunocompromised people was acceptable to key stakeholders. Next slide. Moving on to feasibility. Next slide. The question we're trying to answer here is an additional dose of mRNA COVID vaccine feasible to implement among immunocompromised people? Next slide. In general, there are high levels of interaction between immunocompromised populations and the healthcare system which provide opportunities for an additional dose following the primary series. mRNA COVID-19 vaccine supply in the U.S. is sufficient to make an additional dose for immunocompromised people feasible. Testing for antibodies following vaccination is not recommended, thus reducing the complexity of a recommendation for an additional dose. Next slide. The work group felt that yes, an additional dose of mRNA vaccine is feasible to implement among immunocompromised people. Next slide. Moving on to resource use. Next slide. In addressing if an additional dose of mRNA vaccine given to immunocompromised people is a reasonable and efficient allocation of resources. Next slide. The U.S. government has purchased 600 million doses of mRNA vaccines. Vaccine is available at no cost to the recipient. No studies have evaluated cost effectiveness regarding the use of COVID-19 vaccines among immunocompromised, nor a third dose. Immunocompromised patients experience high medical costs at baseline and are at high risk of hospitalization. The cost of an additional dose of COVID-19 vaccine is small relative to these costs. Next slide. It should be noted that the work group has previously concluded that the cost effectiveness may not be the primary driver for decision making during a pandemic and for vaccines under use, under an emergency use authorization. Next slide. The work group felt that yes, an additional dose of mRNA vaccine given to immunocompromised people is a reasonable and efficient allocation of resources. Next slide. And finally, equity. Next slide. So the question we're attempting to answer here is, what would be the impact of an additional dose of mRNA COVID-19 vaccine given to immunocompromised people on health equity? Next slide. So to review, health equity is when everyone has the opportunity to be as healthy as possible and no one is disadvantaged from achieving this potential because of a social position or other socially determined circumstances. There are a number of immunocompromised groups in the United States who could be disadvantaged with respect to an additional mRNA COVID vaccine dose. Those people include those who may experience limited access to vaccines because of their place of residence or socioeconomic status or personal characteristics, or those who belong to a group for whom vaccine hesitancy is high. In addition, for the time being, those who receive Janssen COVID vaccine will not be eligible for an additional dose of mRNA vaccine. Next slide. In the general U.S. population, great strides have been made towards equitable uptake of COVID-19 vaccines, but there is still room for improvement. We may see similar patterns of uptake among immunocompromised people. Next slide. Equitable application of this intervention can be bolstered by a multi-pronged approach to ensure access. Making sure mRNA vaccines are available at primary care providers, specialist clinics serving immunocompromised patients, as well as FQHCs, rural health clinics, and community health centers, as well as hospitals and pharmacies. Next slide. The work group felt that an additional dose of mRNA COVID-19 vaccine given to immunocompromised people would probably have no impact on health equity. Next slide. So, in summary, next slide. This slide highlights all the workgroup judgments for each of the ETR domains. The workgroup concluded that a COVID-19 vaccine in immunocompromised people is an important, COVID-19 disease in immunocompromised people is an important public health problem. The anticipated desirable effects of an additional dose of mRNA vaccine are large and undesirable effects expected to be minimal, favoring the intervention. The certainty of the evidence was not formally graded. The workgroup felt that the target population valued the intervention and that the intervention was acceptable to stakeholders, feasible to implement, and a reasonable use of resources. The workgroup thought an additional dose of mRNA vaccine for immunocompromised people would probably not impact health equity. Next slide. Overall, most workgroup members felt that the desirable consequences clearly outweighed undesirable consequences in most settings. Next slide. After reviewing the totality of information presented in the evidence to recommendation framework, the workgroup discussed the type of recommendation to propose to ACIP. The options are: we do not recommend the intervention, we recommend the intervention for individuals based on shared clinical decision making, or we recommend the intervention. Most workgroup members supported we recommend the intervention. Next slide. So to start the discussion today, we'd like to leave ACIP members with the following questions. Concerning the intervention, does ACIP support the intervention of an additional dose of mRNA COVID-19 vaccine following a primary series in immunocompromised people? And second, the population. Balancing potential benefits and potential harms, what is the optimal lower age threshold for the additional dose intervention in immunocompromised people? Before I turn it over to the chair, next slide, please. I'd like to thank all of the people who have worked tirelessly to pull this presentation together and without whom it would not be possible. So let's go back to the previous slide. And with that, I'll turn it over to you, Dr. Lee.
Thank you so much, Dr. Dooling, for that outstanding presentation. Before we take questions, and I appreciate our colleagues are putting their hands up in the chat, I just want to ask Dr. Sanchez, who's been able to join us, if he could state his name, affiliation, and any conflicts of interest.
Thank you, Grace. This is Pablo Sanchez. I'm a professor of pediatrics in neonatology and pediatric infectious diseases at Nationwide Children's Hospital, the Ohio State University in Columbus. I have no conflicts. Thank you.
Thank you. Terrific. Thank you so much. And I am going to now call on our ACIP members. And again, I'll just remind folks, if there is a response to an item on the table, please try and indicate so. We'll start with Dr. Alt.
I had a question for Dr. Oliver about the background information. On slide 15, I know there's 63 studies there. On slide 15, is there any information about HIV mixed into those studies, any of those columns? I'm asking about the HIV positive population.
Hello, this is Dr. Dooling. Are you referring to the slide 17, which has various immunocompromising conditions and their overall seropositivity following a primary series?
Yes, I am. When I printed them out yesterday, that was slide 15. So you were looking at data.
So no, there wasn't sufficient information specifically in HIV positive populations to present the data as a body of evidence here. Over.
Thank you. Dr. Paling?
Hi, Dr. Dooling. First of all, thank you for a very thoughtful and precise conversation about this important topic, and to all the members of the work group. I wanted to answer your question and say, yes, I agree with the supporting of the information that the benefits are tremendous and the potential negative impacts are minimal, and so I agree that we should recommend that. The second part, I wanted to spend a little bit more time on children and address that answer. And so my thought is that children 12 to 17 years of age have moderate and severe immunocompromising conditions that reflect the full spectrum that occur in adults. In addition, leukemia and lymphoma are common cancers in children. And the mechanism creating the immunocompromising conditions are similar for both children and adults. And when we looked at the response to the Pfizer mRNA vaccine, which is the only one with an EUA for children, it was similar for children and young adults. Given that the data suggests that breakthrough disease 40 to 44% of that occurs among immunocompromising conditions, I think it's very important that children 12 to 17 years have access to additional dose. Yeah, I think it's also very important that it's an official recommendation, because I do, having noted that some people received vaccine without an additional EUA, I do think it's important for health equity. You also have to recognize that some of these children will be in schools, and so this becomes of paramount importance. And I also want to appreciate that the Pediatric Infectious Disease Society and the Children's Oncology Group support including children 12 to 17 years of age with immunocompromising conditions. Thank you.
Thank you. We'll move to Dr. Chen.
Thank you, Grace. I think I have two comment questions. One is regarding the intervention, and I agree that the data supports the intervention, but I do have a question comment about the way that it's worded, because, and again, it may be limited by the FDA's EUA amendment, which is I would endorse a statement where we were to allow an additional dose of an mRNA-based vaccine in any primary series that was completed. And I'm not sure if there is going to be more precise language which would state something to the effect of only if they had received a primary series around an mRNA vaccine. So again, I guess I'm going back to a consequence of people who received the J&J vaccine as their primary series. And again, scientifically, I think that there should be data that supports that a booster dose after a primary series should be very valuable for protection.
Thanks, Dr.
So I guess my second comment is about population. So I wonder if the data is suggesting that for at least, say, for example, the hemodialysis patients who largely do respond well to vaccination, but still do have a significant detectable decrement in vaccine efficacy as a population. This also represents a population that frequently has to contact medical facilities 3 times a week, typically for hemodialysis, and need to be, in for a long duration of immobility within an indoor space, for their 3 to 4 hour session for a dialysis. So again, these people may be susceptible to localized outbreaks. There are also people who are probably more susceptible to having more severe disease. So I'm just looking at this and making sure that I would like to have the recommendation allow for a population a little bit more broad than what the EUA suggests. And I'm reading the EUA language as saying something to the effect of, solid organ transplant level immune suppression. But then our data that we just reviewed suggests that hemodialysis doesn't approach that level. So I guess it's a matter of interpretation of what we think approaches the level of solid organ transplant immunosuppression. So I'll stop there.
Dr. Chen, this is Dr. Cohn. I can jump in. So to answer the second question, there is a follow-up presentation after this one where we will specifically outline what we are considering in the clinical considerations document, how we're providing guidance to clinicians about who would be considered similarly immunocompromised. So I would hold your question till that presentation. With regards to the first question, we understand that individuals who are immunocompromised who received J&J vaccine are not included in this EUA. As Dr. Marks indicated at the beginning, there were not data to support inclusion of that population in the EUA, and we need to keep our recommendation boundaries within the considerations of use in order to ensure that these vaccines are being implemented appropriately under the EUA. However, we absolutely understand that this is an important issue that needs to be addressed. We're working to address that population. And I also just want to remind everyone that given the way that these vaccines rolled out and when this population was eligible for vaccination, J&J vaccines have compromised many fewer doses overall. Only 12 million people have been vaccinated compared to 149 million with the mRNA vaccines. And of those 12 million, it's likely to be a very small number of those would fall into this severely immunocompromised group, just given the timing of when that vaccine was available. So I just want to acknowledge that that is absolutely something we are working on, but at this meeting, we need to stay within the boundaries of the EUA. Thanks.
Thank you, Dr. Cohn. Dr. Marks, do you have any additional comments or any other suggestions?
So thanks very much. I think Dr. Cohn answered it very well. We do understand the challenges here, and because of that, we will continue to work very diligently to try to have solutions. We had to do what we're doing based on the data that we have in hand, and so that's why we are where we are. We think that at least there is a solution here for the very large majority of immunocompromised individuals, and we believe that we'll probably have a solution for the remainder in the not too distant future.
Thank you, Dr. Marks, for those comments. I'll ask Dr. Cotton.
Thank you. I'd like to express significant support for having additional doses of the mRNA vaccine in immunocompromised patients. Over the past almost year and a half, I have taken care of many patients with life-threatening disease, and including deadly disease, and even after vaccination. And pretty much every week, I have known of patients who are immunocompromised and in the hospital. They did all the right things. They're just suffering from a lack of good vaccine protection. We know that vaccine efficacy is diminished in this population. And thanks to our colleagues in Canada and in France, we have good data showing improved vaccine immunogenicity. It's somewhat unfortunate that we weren't, because of the EUA, able to do such studies in the United States because it's very hard to muster a research response given the issues regarding a need for an IND. So I very much support this, and I also speak for my patients and many patient advocacy groups who also express tremendous support for this. So we're very appreciative both to the ACIP, CDC, and the FDA for doing that. I do want to say that I disagree somewhat with the equity decision, and that there probably is not an impact on equity. I have definitely noted that many of my patients who have told me that they have gone out and gotten a third dose, not under a physician's guidance, but they have read websites, they have read the New England Journal of Medicine, they have read the New York Times, other places. And so because they are educated and savvy, they have gone out and figured out how to get themselves additional doses of vaccine. I have definitely noted a lack of equity, and I am really happy that the FDA and ACIP will be moving forward on this so that we can appropriately message, discuss, and provide additional doses of vaccine to people who may not be such self-advocates. So I actually think that there will be a significant improvement in equity through what we are working on yesterday and today. Regarding the optimal lower age, I have also taken care of many pediatric patients over the years, and in discussions with the pediatric oncology group, rheumatology, and transplant groups, they all supported a lower age. So because the lowest age we have right now is 12, we as a group would definitely support access to additional doses of vaccine for this vulnerable population. Even understanding that there may be some enhanced risks in this population in general, we don't know that those risks exist in the immunocompromised population, and I'm hearing many devastating stories about young immunocompromised people being admitted to hospital with life-threatening disease. So if it were my child who were immunocompromised, I would definitely try to get them an extra dose of vaccine if they were over the age of 12. Thank you.
Thank you for those comments, Dr. Cotton. Dr. Long? Dr. Long, I see your hand raised. Would you like to make a comment or add to the discussion?
I'm sorry, you're not hearing me?
We hear you now.
We hear you now. Thank you.
I'm sorry. I'm in the boonies in New Hampshire in front of a gorgeous lake. So, can you hear me now?
Yes, we can hear you. Thank you.
Okay, great. I'm certainly going to be in favor of this intervention and agree with everything that has been said. I would like to see if could be a little bit more of a discussion maybe from the work group members about the lower age. So because there's such variability in responses to the vaccine in the relatively few groups and few numbers of cases that you've shown us, it's not the severely immunocompromised who could really so greatly benefit from this. I'm not worried about them. I'm a little bit more concerned about potential harm for those younger children, 12 through 17, who have in fact had a robust response to the first 2 doses and now would get a 3rd dose potentially 1 month after their 2nd dose. And it just makes me think more of setting up for those individuals the potential situation of myopericarditis or other immune or inflammatory responses. So the question is, especially for the younger group, have we ferreted out as best we can those that are severely immunocompromised who would most certainly benefit, and not just put up some tag-along groups like hemodialysis patients and like some other immunocompromised individuals, especially HIV who don't have severe immunocompromise, just set them up for potential harm. I did notice, Dr. Oliver, that you mentioned a few times that most of the work group agreed. I wonder if you could tell us about any dissenting opinions or any discussion about potential harm in the 12 through 17-year-olds. Thanks.
Dr. Long, this is Amanda. I can start and just by reminding you that unfortunately, when the ACIP work group discussed this, they only focused on 18 and above, which is why we have this specifically as a question, number 2 for you all, because the ACIP work group we weren't aware of what the age indication would be of this EUA, and so they focused on the adult population. So I think that is there wasn't a discussion, and Dr. Dooling can certainly talk about the dissension for the other topics, but I think given that you're focused on that age group, it may be nice to hear from other ACIP members about maybe those who are on the work group about that question.
Yeah, thank you. This is Dr. Lee. I'm actually going to chime in because I am on the work group and also because of the, I'm on the vaccine safety work group. And I'm actually going to ask in the meantime while I'm talking for other ACIP work group members, if you'd please raise your hand and contribute. This would be terrific. I'll just give my own opinion, which is that I think that the age down to 12 is actually helpful from an equity and access standpoint, in part because we have, as clinicians, seen immunocompromised children who remain at risk for contracting COVID infection. And, you know, we're reopening schools. We're in this whole other era where we're really trying to support the safety of all of our patients as individuals and as well as and for the teen population in particular in schools. What I would say is just one other comment, well, two other comments. One being that I do think the sort of reactogenicity and then also potentially as sort of a version of that, potentially, you know, myocarditis, pericarditis, it does, in my mind, seem to somewhat correlate with immunogenicity. And I wonder if an impaired immune response is present, whether or not that risk is really modified in individuals who actually aren't responding. So that's sort of one question. In addition, I think in my mind, the benefit-risk balance, when we're really talking about hospitalization and death, even for kids, because they're immunocompromised, also sort of adds to that benefit-risk balance equation. And then just a broad comment, and then I'll call on my colleagues to state that it's a real challenge, I think, for us as clinicians who are also serving on ACIP, because our duty as ACIP members is really to think about benefit-risk balance for the population. Where it gets really tricky is with the immunocompromised population, because there's not a single definition that identifies people who are, for example, moderately immunocompromised. So as an ACIP body, our responsibility is to follow the regulatory authorities in terms of what we're allowed to do and also think about population. But I also encourage us as an ACIP body and as clinicians to really talk about patients and individuals, because I think as clinicians, we want to make sure that we are helping our patients understand the benefit-risk balance, because it is very individualized in immunocompromised patients. And also that we're, trying to, as much as possible, make implementation feasible within the constraints that we're given. But, from a clinical standpoint, we like to keep it simple, make sure that the people who need protection are protected, and then be able to offer that protection. So my hope is that we can get to that harmonized place in the very near term. I'm going to turn it over to Dr. Talbot. Any comments you'd like to make?
Yeah, I agree with everything you say, and I think the main question is, what about the rare adverse events like myocarditis when we're giving a third dose? There's very little data, and so I think that needs to be kept in mind when adding the 12 to 17-year-olds. I do think my only concern about adding a third dose for the immunocompromised is the impression that our immunocompromised population will then be safe. I think the reality is they'll be safer, but still at an incredibly high risk for severe disease and death. And so I think there needs to be a fair amount of counseling and education that goes into this effort. That a third dose will likely improve some of the immune responses, but we will still have a population at high risk. And we need to remind them of that. And we need to remind everyone that they spend any time with to be vaccinated to protect them. Thank you.
Thanks, Dr. Talbot. Any other comments or questions from ACIP work group members or the ACIP on this particular topic? Ms. McNally?
Yes, Dr. Lee, I was hoping that we could hear from AAP on this issue. I'm also wondering if during the work group discussions, any pediatric cardiologists were part of those conversations.
Thanks. Let me first turn it over to Dr. Dooling to answer the latter question. And then fortunately, I see Dr. Maldonado and Dr. O'Leary from AAP and PIDS have raised their hands, so we'll call on them next.
Hello. Pediatric cardiologists have certainly been integral to work group discussions when discussing the myocarditis, pericarditis issues, in fact, also presenting to ACIP. And for the context of this specific discussion on third dose, there were no additional cardiologist subject matter experts brought in. Thank you.
Thank you, Dr. Dooling. Dr. Maldonado.
Yes, thank you so much for letting me make some comments here, and I'm going to be brief, but I absolutely agree that we need to provide additional support For individuals 12 to 18 at this point, I want to point out to all of you that Dr. Lee Beers, the president of the Academy, our Academy of Pediatrics, did provide an open letter to the FDA, really underscoring that issue that we really need to focus on children under 12 as well. And just reiterate that while there is justifiable concern about reported cases of myocarditis, these are, again, extremely rare, and we know that the severity of reinfections right now and the events that we've seen with vaccines have not shown any evidence of adverse immunologic responses, either clinically or in laboratory studies. So these are, at this point, important considerations, but if they would occur, would potentially be extremely rare, whereas we have heard and have seen ourselves the impact of this particular disease on children overall and children, especially who are immunocompromised. And we're concerned about the safety of our children and the fact that they are still vulnerable, even healthy children, and especially our immunocompromised. So the Academy, I believe, and we have not had a formal discussion about this particular issue because it has been so recent, but the Academy stands behind any efforts to provide vaccines for children when they are indicated, and I think that they are indicated in the older population in this subgroup of immunocompromised. It certainly would hold true for our pediatric population and provides them additional options with, of course, with counseling from their providers and their subspecialty providers around benefits and harms and potential risks. Thank you.
Thank you, Dr. Maldonado. Dr. O'Leary?
Yeah, and speaking both as a work group member and also the PIDS representative, Pediatric Infectious Diseases Society, I think I want to speak in support of Dr. Paling, Dr. Lee, Dr. Maldonado, Dr. Cotton, everyone that has said, spoken in support of the 12 to 17-year-old age group. In terms of the potential benefits and harms, certainly myocarditis is a concern. I don't know that it applies any differently, though, to the 12 to 17-year-old age group than the young adult age group, for whom it's also a risk, albeit rare. So I think the discussions that we had in the work group do also still apply to this age group. The only thing I would add is that I think because we don't have as much safety data as we would like in this population, it's a small group of individuals. I think enhanced safety surveillance would be great. I think as part of the communication about this change in recommendation, really communicating to providers the importance of having their vaccinees or having their patients sign up for B-Safe when they get the vaccines, so that we can have more robust data on the safety issues. Thank you.
Thank you. Dr. Zahn?
Great. Thank you, Dr. Lee. Just speaking on behalf of local public health, I think right now with the surge in Delta cases that's happening around the country, there are a lot of settings where COVID is difficult to address, but there's really no setting that's more difficult than the school setting. We all, I think, are very committed to trying to get kids back in school and in-person learning, but those settings are just extremely challenging when there's a lot of COVID in the community, and for, in particular, addressing the issue of immunocompromised children in those settings is just an ongoing issue. And so I certainly would echo the support of others for consideration of the 12 to 17 age group. Certainly, as Dr. Talbot and others have mentioned, there is still going to be ongoing risk for immunocompromised populations. So we still have to think about all the measures other measures we have to do to keep them safe. But I really have to think that we have to take all reasonable measures to protect kids who are 12 to 17, who are immunocompromised. Thank you.
Thank you. And I know we have run way over with this excellent discussion. As a way to kind of close the loop on this issue, I would, perhaps like to request that number one, I just want to recognize that we were under the impression that we were focused on adults as, work group members. I think the pediatric population is incredibly important. What I would say is over time, we hope that with additional data to support these discussions, that we can start to incorporate that in particular for the pediatric population as this rolls out. So, okay, thank you very much. I think we'll move on to Dr. Goswami. Oh, I'm sorry, Dr. Sanchez has something to add. Go ahead, Dr. Sanchez.
Thank you, Grace. I just also want to echo what the others have said in support of additional doses of the messenger RNA vaccines. But I also want to agree with Dr. O'Leary and actually Dr. Long about the need for enhanced surveillance in the younger age group. I'm certainly in support of that, of the additional dose. I know that we are not recommending, or at least it doesn't appear that we're recommending routine testing for antibodies, but I do think that that in the higher, I just wonder, not knowing the full pathogenesis of the myocarditis in the younger adults, whether some antibody testing may be warranted or at least suggested as we try to define what that risk is in those individuals. Because, and I know that we don't have a level of antibody that we know to be protective, but if they have responded to 2 doses, and again, these individuals are seeking medical care. It's not the, so I just wonder whether in some of these individuals, maybe the antibody testing also may be at least an option, if not a suggestion for performing. Thank you.
Dr. Lee, if I could respond to that?
Yes, thank you.
Hi, this is Dr. Kathleen Dooling. So there are 2 primary reasons why the work group agreed with not including an antibody test into a current a proposed recommendation for 3rd dose in immunocompromised. The first, as Dr. Sanchez points out, is that we do not have good information on correlates of protection. There are many different types of antibodies, binding antibody tests, neutralizing antibody tests, and the interpretation of which would be extremely difficult on an individual level, certainly with variability from lab to lab in these tests. Second reason is that, again, due to variability among commercial tests, there are actually no tests that are FDA approved for the purpose of testing antibody levels post-vaccination. So once again, interpretation of such would be very difficult and not particularly useful in a population recommendation.
And this is Dr. Cohn. Oh, go ahead.
So with respect to that, in the studies, how, obviously in the various studies that were presented and have been published, there was antibody testing done. And in all honesty, I have not reviewed the actual testing that was performed, but there has to be some reliability in terms of the testing that was done, and because this is where we're basing the data.
So yes, many of the...
Actually, go ahead, Dr. Dooling.
Okay. So yes, on the data presented, we do rely on antibody testing in various forms, binding antibodies, neutralizing antibodies. Usually studies do a number of these to try to fully characterize the immune response. And we do note a limitation of the data that we presented is that antibody measurement and thresholds do vary by study protocol with that variability between assays that I mentioned.
And this is Dr. Cohn. I just want to mention that we hear all of your comments about enhanced surveillance, and we are absolutely implementing vSafe for looking at their dose and really want persons to participate. but we'll also be looking for other ways to ensure that we are monitoring the safety of third doses in this group closely.
Thank you. We'll move on to Dr. Goswami for a discussion of clinical considerations. Thank you.
Thank you, Dr. Lee, and we very much appreciate the comments and healthy discussion going on, with particularly with so many moving parts. Today I'll be sharing with you proposed clinical considerations for use of an additional mRNA COVID-19 vaccine dose following a primary COVID-19 vaccine series for immunocompromised people. Next slide. Before we launch into the discussion about additional vaccine doses, we did want to respond to a request that was raised at the last ACIP workgroup meeting regarding COVID vaccines and pregnancy. We have posted language strengthening the recommendation for COVID vaccine among childbearing women and pregnant people earlier this week. In summary, COVID-19 vaccination is recommended for all people aged 12 years and older, including people who are pregnant, lactating, trying to get pregnant now, or might become pregnant in the future. It's important to note that CDC and ACIP have never pointed to pregnancy as a contraindication to COVID vaccine, but additional real-world evidence about the safety and effectiveness of COVID-19 vaccination during pregnancy even further demonstrates the benefits of receiving a COVID-19 vaccine outweigh any known or potential risks. And this is particularly important as we are all well aware that COVID-19 itself increases the risk of both severe illness and pregnancy complications. So as of August 11th, last Wednesday, you can find this updated language at our considerations web link here at the bottom of this slide. COVID-19 vaccines do not cause infection in the pregnant person or the fetus, as it is not a live virus vaccine. There are no safety signals we've seen in animal studies. We have reassuring early safety data on mRNA COVID-19 vaccines during pregnancy. Early data suggest mRNA COVID-19 vaccines during pregnancy are effective, and there's no evidence that any of the COVID-19 vaccines affect current or future fertility. You can learn more about CDC's recommendation for COVID-19 vaccination in pregnancy at the CDC IDSA COVID-19 clinicians call, scheduled for tomorrow at 3 p.m. Eastern, and we've included that link at the bottom to register for that as well. Next slide. Moving along, we want to outline the process for the consideration of an additional dose of COVID-19 vaccine in immunocompromised people, which is being discussed today. As many of you know, the first step is data review to assess the safety, immunogenicity, and implementation features related to use of an additional dose of COVID-19 vaccine in this population, which Dr. Dooling just presented. Then there is regulatory allowance by FDA. At this point, FDA has issued an emergency use authorization, or EUA amendment, for both Pfizer, BioNTech, and Moderna COVID-19 vaccine that allows ACIP to make recommendations under an EUA. Once there's regulatory allowance, CDC or ACIP can have a clinical update with clinical considerations or recommendations for use. This presentation will review the proposed interim clinical considerations for use of an additional dose of mRNA COVID-19 vaccine in immunocompromised people. Next slide. To make sure we're all on the same page, it's important to keep in mind that there are two distinct potential ways an additional vaccine dose can be used. The first way, an additional dose can be used as after, but in association with a primary vaccine series. Administration of this additional dose is needed when the initial immune response following a primary vaccine series is likely to be insufficient. Now, contrast that with using an additional dose as a booster dose. This is a dose of vaccine administered when the initial sufficient immune response to a primary vaccine series is likely to have waned over time. We do want to clarify right away that the need for and timing of a COVID-19 booster dose have not been established, and you'll hear more from Dr. Oliver on that in a bit. But for now, we're going to focus on this first category. Next slide. Next slide. The focus of the proposed clinical considerations are as follows. For people with moderate to severe immune compromise due to a medical condition or immunosuppressive treatment, the potential to increase immune response coupled with an acceptable safety profile support consideration for an additional dose of mRNA COVID-19 vaccine following an initial 2-dose primary mRNA COVID-19 vaccine series in this population. Next slide. So you've heard about some of the proposed categories for moderate and severely immunocompromised people. This is the proposed list developed from a combination of resources, including the ACIP General Best Practice Guidelines for Immunization, CDC Yellow Book, and the 2013 IDSA Clinical Practice Guideline for Vaccination of the Immunocompromised Host that we would propose be listed on our CDC considerations page as follows. First, patients undergoing active treatment for solid tumor and hematologic malignancies, patients who received a solid organ transplant and are taking immunosuppressive therapy, patients who received chimeric antigen receptor T-cell or hematopoietic stem cell transplant within 2 years of transplantation are taking immunosuppressive therapy, moderate or severe primary immunodeficiency, advanced or untreated HIV infection, active treatment with high-dose corticosteroids, that is 20 milligrams or more of prednisone or equivalent per day, alkylating agents, antimetabolites, transplant-related immunosuppressive drugs, cancer chemotherapeutic agents classified as severely immunosuppressive, tumor necrosis factor blockers, and other biologic agents that are immunosuppressive or immunomodulatory. Next slide. There are chronic medical conditions that may be associated with varying degrees of immune deficit that was specifically raised during some of these comments, and the patient's clinical team is best able to assess the degree of altered immunocompetence and optimal timing of vaccination, with specific attention paid to current or planned immunosuppressive therapies. Whenever possible, mRNA COVID-19 vaccination doses, including the primary series and additional dose, should be given at least 2 weeks before initiation of immunosuppressive therapies. Factors to consider in assessing the general level of immune competence of patients with chronic diseases include disease severity, duration, clinical stability, complications, comorbidities, and any potentially immune-suppressing treatment. We do want to highlight, as was discussed earlier, and is proposed wording we would put very clearly on our considerations page, that utility of serologic testing or cellular immune testing to assess immune response to vaccination and guide clinical care, such as in the need of assessing for need of an additional dose, has not been established and potentially would not be recommended at this time. Next page. Implementation considerations that additionally we would list. The additional dose should be the same mRNA vaccine as the primary series. Alternate mRNA product can be used if primary series product is not available. Until more data is available, the additional dose would be administered at least 28 days after completion of the initial primary series. Currently, there aren't data to support the use of an additional mRNA COVID-19 vaccine dose after a primary Janssen COVID-19 vaccine in immunocompromised people, but we would list on our site that FDA and CDC are actively working to provide guidance on this very important issue. Next slide. In response to ACIP feedback, we very much would plan to emphasize the importance of infection prevention measures, recognizing this additional layer of protection. Here, immunocompromised people, including those who received an additional mRNA dose, should be counseled about their continued potential for reduced immune response to COVID-19 vaccination and their need to follow prevention measures, including wearing a mask, staying 6 feet apart from others they don't live with, and avoiding crowds in poorly ventilated indoor spaces until advised otherwise by their healthcare providers. Close contacts of immunocompromised people should also be strongly encouraged to be vaccinated against COVID-19. Next slide. We would plan to put updates of CDC clinical resources regarding administration of the additional dose associated with the primary vaccine series for some immunocompromised patients that you'd be able to find at this web link. Next slide. With that, I'll close with acknowledgments to colleagues on our CDC COVID-19 Response Vaccine Task Force. Thank you.
Thank you so much. This presentation is now open for questions or comments. I'll take it from the ACIP members first. Dr. Long.
Yes, thanks very much. You introduced a new concept here that I hadn't thought about in the initial recommendation, and that is one of you were talking about chronic medical conditions. So the slide that had that on the top, chronic medical conditions, and then about 2 points later, there was in parenthesis, to consider giving dose 1, 2, and 3 before immunocompromise. Now, that's a totally different situation, in my opinion. And for instance, if you're preparing someone for a transplant, the transplants being those that are most likely to not respond adequately, I sure wouldn't want to do that. That's the one in which I'm with Dr. Sanchez. I'd want an antibody titer to tell me that someone needs a third, because it's almost certain that for those transplants, it's after the beginning of the anti-rejection medicine that patient becomes immunocompromised. So what led you to think about giving 3 doses in preparation for immune compromise?
Can you pull up the slide, please, that we're referring to? Sorry, Dr. Long, we're just, can Dr. Lee, do you mind going to the next question? We're trying to make sure that we address
that. It. Yes, this is the slide. Mm-hmm. And it's the third bullet.
How about we give you, we go to Dr. Talbot, and then we'll come back to Dr. Long's question. Dr. Talbot?
Yeah, I really thought this was well done. The only question that I have is timing of this third dose. We have seen other countries have spaced out their first and second doses and have had improved immune responses. And this makes sense immunologically. So I'm guessing I'm looking for some input, or should we consider some clinical guidance on when to give this third dose? I would hate for someone to go 3 weeks after their second Pfizer and get another Pfizer. Because I don't think that they will get the optimal response from that third dose. We're not giving them the best chance to succeed. And so many of our previous vaccination time periods have been day 0, 1 month, and 6 months. And so should we consider at least giving some time between the second and third dose to allow for the best immunologic responses in these patients and giving them a better shot at reaching levels that would be protective?
Hi, Dr. Talbot. This is Dr. Oliver. I'm going to take it because there was discussion going on regarding the last question in the room. So the EUA was written for at least 28 days or at least a month after the primary series. So that is what was incorporated here. We're happy to hear kind of additional considerations. I think 2 things, though, that I will point out. Some of these individuals, have had time elapsed since when they got their primary series. Individuals with underlying medical conditions, including immunosuppression, were some of the earlier phase of the vaccine rollout. So many of them will be several months beyond when they got their primary series. The other thing to point out is if individuals have not responded to the first 2, and to say they had to wait at least 6 months could put, a substantial time period between where we are worried that they're not protected between when we could give that additional dose. So that is why it was written the way it is. But happy to have conversation around this and potentially even input from Dr. Cotton, who would be considered one of the global subject matter experts on this. Over.
And before Dr. Cotton speaks, maybe she can also speak to this point. My concern is if someone hasn't responded to 2 doses and their level of immunosuppression has not resolved, they likely won't respond to a third dose. I'm looking at those who've had a response, but not an adequate response. I think that was my thought. I would love to hear Dr. Cotton's thoughts.
Great. I call on Dr. Cotton to comment.
Thanks. I think that this is a very heterogeneous population. It's one thing if we're talking about organ transplant recipients who maybe are getting further and further away from the time of their transplant, at which point we know, based on all other vaccine studies, that the immunologic response to vaccination improves over time, versus if it's, say, a population that's getting rituximab, where we have seen greatly diminished serologic response to COVID-19 and other vaccines. So I think it's a heterogeneous population. In the absence of data and with an intense worldwide pandemic, I would be sort of reluctant to make it 0, 1, and 6 months, in that if somebody, say, I've seen plenty of people who just finished their second vaccine, would I actually make them wait another 6 months at this point? And, based on the data by Kamar et al. From France, or the data from Kumar in Toronto, I would be reluctant to have a long period of time before they undergo additional doses of vaccine. So I sort of agree with what the FDA had proposed. It's possible that we may get to a point where they need not additional doses of vaccine, but actually booster doses. And thank you for providing that clarification in the talk. But they may need booster doses 6 months or longer at some point further down the pipeline. I have to say, I'm not always the biggest fan of these sort of rigid intervals for vaccines, unless there's a strong body of data stating that 0, 1, and 6 months is the perfect answer. So I would allow for flexibility, but I would somehow have clinicians be thoughtful. And if people are just coming off a dose of, like a course of high dose steroids, or if they've just been treated for rejection, or if there's some reason that they've had a significant augmentation in their overall immunosuppression, I would not necessarily have them get their additional dose right at that time, because it's unlikely that the vaccine's really doing anything. So I would try to think hard about timing. I'm not, and kind of changing paragraphs, I'm not entirely convinced that people need 3 doses before the initiation of immunosuppressive therapies. Although that may be true for some, for example, the patients who have kidney disease and on dialysis, in whom we have noted, mild to moderate immunosuppression, I would say, in the COVID-19 context. So maybe they could benefit. But I don't know that everyone heading into immunosuppression necessarily needs it. And one thing I don't want to encourage is delay of necessary immunosuppression to treat what can be dramatic autoimmune and other diseases needing immunosuppression. So somehow I tried to kind of think about clinical status and think about need for immunosuppression and those things as we sort of network in the vaccine recommendations. And I appreciate that this is challenging.
Hi, this is Dr. Kathleen Dooling. I'd like to respond to a few of those points. First, as you highlight, Dr. Cotton, this is a highly heterogeneous group with very complex medical needs that are going to vary by condition and by individual. So our attempt here was to make these clinical considerations a starting point that will definitely need to be adapted by the clinical care team treating these individuals. So to start with point 1, the 28 days, that is meant to be a minimum and absolutely needs to be adjusted based on the individual considerations of the treatment regimes for an individual. So again, that's just a starting point. As we know, the vast majority of immunocompromised people who have received their primary series did it months ago. So again, we will have longer intervals. It should be noted that many of the studies that were presented provided a third dose at an interval that was 1 or 2 to 3 months beyond the completion of the initial primary series. To move on then to the third bullet, which is whenever possible, vaccination should be given at least 2 weeks before initiation of immunosuppressive therapies. That should also be worked into and adjusted to the individual considerations of any given patient. It is a principle of vaccination that whenever possible, vaccination should be given prior to instituting immunosuppressive therapy for maximal protection from that vaccine. And I think that's the general point that we're trying to get at there. And perhaps it might be improved if we say at least 2 weeks before initiation or resumption of immunosuppressive therapies, understanding that many of these patients will have a fluctuating course of immunosuppression.
So this is Amanda. We will take these comments so far regarding these particular bullet points and edit this language before we put it out.
Thank you. And we can review that perhaps prior to the vote. Dr. Talbot, do you still have your hand up? No. Okay. Dr. Sanchez would like to respond. Go ahead, Dr. Sanchez.
Yes, thank you. I think Dr. Long's point, though, is to some of these individuals, and getting back to the dosing before initiation of immunosuppressive therapies, is whether, I think that it depends certainly on the condition before initiation of immunosuppressive therapies, because some of them, I mean, with routine vaccination, we just give the routine vaccines at the appropriate dosing rather than additional dose, and whether some of those individuals actually need a third dose is what I would think. That some of them may just need the routine two doses before and not need a third dose.
Dr. Sanchez, I think that the considerations, this is similar to recommendations around the additional dose, the 2-dose primary series for MenACWY vaccines. I think this is almost to be considered like a primary series for persons who are immunocompromised rather than an additional dose. We used the word additional dose to try to not, we thought it would be an easier way to address it, but I think that's sort of the approach that we were taking, that most people who were immunocompromised should, the most number of people would respond after a third dose. But we can certainly, I just want to remind everyone that we're not voting on this language. We're just voting on whether to make the recommendation or not, but we can, I think this has been really helpful so far, and we have some other people to speak, but the purpose here is to provide some different options or guidance for providers who are looking for guidance, but I think it's absolutely going to be according to the individual provider and patient about the best course of action.
Thank you, Dr. Cohn. I'm going to we have 3 hands raised. I'm going to turn to those 3 hands, and I think we will conclude unless there are any burning issues that the ACIP members would like to add or discuss. Dr. Kane?
Mute myself. One of the concerns I have from a health equity standpoint is that currently right now, about 25%, at least in my locality in Indianapolis, Indiana, are using Johnson & Johnson vaccine. And although we're not going to make any recommendations related to this, if I'm having new people, because of vaccine hesitancy in our African-American population, our Latino population, if I'm doing a big push for vaccination and I have immunocompromised patients like sickle cell, HIV, chronic renal failure, which is disproportionately higher here, should we now be recommending that they receive a messenger RNA vaccine instead of the Johnson & Johnson? Because I don't know how long it's going to take and how many cases we're going to have to see for the safetyness of using a Janssen vaccine. So what are we doing currently now for our providers when we have these patients in these settings in terms of what vaccinations we can recommend? That's my first point. Real quickly, my second point is, since I've already received the Johnson & Johnson vaccine, should we consider subsequently to start a new vaccination series with a messenger RNA vaccination in order to protect my patients? I'm going into the Delta variant. It's really contagious out there. Transmission is increasing greatly. I don't have the luxury to wait to get that protection in them 4 or 5 months from now.
Thank you for your comments. I'm going to ask Dr. Goldman to comment next.
Hey, thank you, Dr. Lee. I'll be very brief, and I do want to touch on a little different approach to the equity piece. Now, first, I do support giving an additional dose. I don't know how beneficial it will be in some of these patients who are immunocompromised, but in the clinical considerations, my concern is the operationalization of it in how patients are going to get the vaccine, in the sense of, will they be required to prove they are immunocompromised? Will they be asked to provide a letter? Are people going to game the system who just want a third dose? I'm already seeing it with patients after the FDA's announcement calling my office, wanting me to write them a letter to justify that they need a third dose when they are not immunocompromised. So I'm concerned that if localities will require some type of proof, and patients may not have access to physicians in the first place to even write letters that don't need to be written in the first place, that they're not going to get access to an additional dose that they may need. I don't know how to solve this problem, but I want to bring it to the committee's attention that these kind of issues are going on at the ground level, and that could promote that could be a barrier to access to care in how localities operationalize giving out a third or an additional dose for the immunocompromised, and just to be cognizant of that. Over.
Thank you. And I just want to just say out loud that we are acknowledging and processing all these comments. I just want to make sure we get to all of them, and then if our CDC colleagues would like to respond, we'll give them an opportunity. Dr. Freihofer?
Sandra Freihofer, American Medical Association, speaking as a practicing physician. Thank you so much for this great discussion. I noticed a discrepancy between the population of immunocompromised people that was part of Dr. Dooling's presentation on slide 6 and the list of immunocompromised people on Dr. Goswami's presentation, also on slide 6. And it was Dr. Goswami's list did not list patients with asplenia and chronic renal disease. I did note that on slide 7, that the second bullet mentioned the value of clinical evaluation, that the patient's clinical team is best able to assess the degree of altered immunocompetence. But I wanted to, was that an omission by choice, or was it just left off by accident?
Thank you. Actually, since this is a clarification question, Dr. Dooling, would you be able to respond quickly, and then we can...
Hi, this is Dr. Goswami. No, thanks for that question and the point of clarification. It was not an intentional point to make those discrepant. It was just in the interest of emphasizing that chronic medical conditions, while initially listed, could be perceived as a big bucket. It's important to keep in mind that, of course, individual patients need to be considered in terms of their level of immunocompetence. And whether it be for a dialysis patient, or whether it be for someone with asplenia, those are certainly two examples, and there are many, many more. So as far as we're concerned, those are aligned, and that was just probably a typo or a logistics issue.
Thank you so much for the clarification.
Thank you, Ms. Howell.
Yes, thank you. Just a couple of questions and a comment. For the advanced or untreated HIV, I'm wondering if CD4 counts will be used similar to what's used on the adult immunization schedule for live vaccines, if that's how it will be defined. And then looking at, on this slide, bullet number 4, I'm thinking about practically implementing this, and that could apply to a lot of people in a long-term care setting. And so I'm wondering if there were any consideration given for whether or not this EUA authorization then could just be for all long-term care residents, and if their level of immune competence is similar to people who have immunocompromising conditions. And then just trying to think about practically implementing this. I represent the Association of Immunization Managers and communicating this to the public. as much as possible, if there can be examples of chronic medical conditions, so people are able to self-identify, it will be, as we know in the past, when we recommend vaccines for people with different conditions, it's much more difficult to communicate that, and people are going to have to self-identify. So we're going to have to be very clear in who is immunocompromised and who's not. And so if we're talking about chronic medical conditions, it would be helpful to have very specific examples that we can put out to the public.
Thanks so much. This is Amanda. Do you mind if I respond, Dr. Lee?
Go ahead, please.
Okay, I think that we're recognizing now that that first bullet is probably confusing. This EUA is intended to be for people with moderate to severe immunosuppression, and not persons with chronic medical conditions for which there might be some mild associated immunosuppression. If you go back to the EUA, it is equivalent to immunosuppression after a solid organ transplant. And so I just want to clarify that the intent of our clinical considerations is to allow for some flexibility for providers to assess their patients' immunosuppression, and individuals will need to kind of attest to their immunosuppression in order to get vaccine. But the intent of this is to limit this to individuals for which are considered under the EUA to be moderate or severe. And so, for example, would not include long-term care facility residents or persons with diabetes, persons with heart disease. Those types of chronic medical conditions are not the intent here, and we can certainly revise this language to be more clear.
Thank you. And I don't know if there's any other issues you'd like to address, but I just want to say that this discussion is exactly what is helpful to clarify and make sure that there is clarity on both the recommendations and the clinical considerations. So I thank all of our ACIP members and our liaisons and ex officio members for contributing to this. Dr. Cohn, is there anything else that your team would like to address?
Hi, this is Dr. Dooling. I'd like to respond to a couple of the great points that were raised. Those regarding whether or not any kind of medical sign-off on immunocompromised eligibility will be required. This will not require that. This is a self-attesting. We are not recommending that either prescriptions or a physician sign-off be necessary for individuals to receive an additional dose of mRNA if they're immunocompromised. There were great points raised about new patients presenting for primary series vaccination and how to weigh the options of Janssen vaccine or mRNA vaccine. I think at this point, both are authorized under emergency use for immunocompromised persons, and it will probably warrant a discussion between patient and vaccinator whether the one dose of Janssen versus initial primary series followed by an additional dose of an mRNA vaccine is the right choice. So thank you for those great points.
Thank you. And with that, I want to thank our presenters again, and I will ask that we will now recess until 5 after the hour for a short break, at which time we'll return to begin public comments. Thanks, everyone.
All right. Recess.
Dr. Lee, are you ready to restart the meeting?
Absolutely. You're very much on time, Dr. Cohn. Thank you. Okay, it's now, let's see, it is 10:05 my time, and we'll now reconvene the meeting to begin public comments. I'd like to welcome and thank our public comment speakers for addressing the committee today. All of the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via lottery. For our speakers today, we have a limited public comment period, and in order to make it through all the listed speakers, it's extremely important each speaker limits his or her remarks to 3 minutes. There will be a timer displayed on the screen, so you'll know how much time you have left. And I just want to thank our speakers again, and we look forward to your comments. So our first public commenter for today is Ms. Hannah Kaufman. Ms. Kaufman, please go ahead.
Hello, my name is Hannah Kaufman, and I am immunocompromised. I live with ankylosing spondylitis and Behçet's disease. I currently take 3 different immunosuppressant medications, including an antimetabolite, a biologic, and corticosteroids. I was hospitalized twice in June for a bad flare of my autoimmune disease triggered by a relatively mild non-COVID infection, and I am speaking to you today from the infusion center where I am currently being treated with Remicade. My doctors are waiting on clearer guidance from you before they can recommend moving forward with any kind of third vaccine dose recommendations for me. My plea is that the guidance you come up with and vote on today defines immunocompromised as broadly as possible. I implore you to leave as much to the discretion of patients and healthcare providers working collaboratively to determine individual risk-benefit of third doses on a case-by-case basis. I want to stress the importance of recommending third doses for people in all categories of immunocompromise and immunosuppression. It is terrifying to know that vaccinated solid organ transplant recipients are 485 times more likely to be hospitalized or die than their healthy vaccinated peers. Still, many of us don't know our risk level. I haven't had a transplant. Am I 300 times more likely to die? Am I only twice as likely to die, which is still horrifying? What is the threshold where I should get a third dose? Quite honestly, death is not the only thing I fear, and not even the thing I fear most. What truly scares me is the possibility of developing long-term COVID complications that will further degrade my quality of life, something I don't even know the likelihood of because we aren't keeping track of it. I need to do all I can to avoid infection in the first place. The world has become much less safe for people like me since people took their masks off in May. I was unable to even pick up my immunosuppressant medication from the pharmacy yesterday because there were unmasked people bumping into me from all sides in a zip code that is only 39% vaccinated. For immunocompromised people with less effective vaccinations, the recommendation has been to build a shield around us of others who are vaccinated and others who are masked. These are wonderful aspirations, but not at all in our personal control. Please give all of us who are immunocompromised a fighting chance to protect ourselves in a world where we have to rely on others to make the right choices, and many refuse to do so. Please keep the interpretation of immunocompromised as broad as possible. Don't just do it for people like me. Do it for the caregivers who are exposed to us. Do it for the children we live with who are too young to be vaccinated and are being thrown back into schools without masks. Do it for the population as a whole. I don't want to be the one who incubates the next variant of concern. Thank you.
Thank you very much for your comments. Next, we have Ms. Elizabeth Fashing.
Hello. My name is Elizabeth Fashing. I'm from Erie, Colorado, and I am proud to be the Executive Director of Colorado Immunization Advocates. Today, though, I'm speaking as a parent with 2 children who are not old enough to receive a COVID vaccination and to urge the approval of the vaccine for those under 12 as quickly as possible. When my children were infants and too young to receive all of the standard childhood immunizations, I felt some trepidation. I knew there were some members of our community who chose not to vaccinate their children and thus put my children at risk. But I at least had a light at the end of the tunnel. I knew exactly when each of my children would be fully vaccinated, and once they were, I could breathe a sigh of relief. Today, that trepidation is much different. There is no light at the end of the tunnel. I have no idea when my children will be able to get vaccinated against COVID. Instead of the highly localized outbreaks of vaccine-preventable diseases that were easier to avoid a few years ago, COVID is everywhere, and my options to protect my kids from it are limited. They don't come to the store with me. We haven't traveled with them on airplanes or visited the public spaces we used to enjoy, like the museum. My husband and I got vaccinated as soon as we could. We wear masks everywhere. Next week, my kids go back to school. I am more worried this year than last year because of the contagiousness of the Delta variant and the number of children currently infected and hospitalized. Although we are fortunate to live in a county which has mandated masking for all students and staff in schools, I still know that the best way to protect my children is to get them vaccinated. Other friends live in districts which don't have mask mandates. Some of my friends have children who are immune compromised. Only one district in our state is requiring teachers and staff to be vaccinated. We need to get our kids access to the vaccine. Please, on behalf of all parents who are facing such an uncertain school year and who want to do everything we can to protect our children from COVID, please approve the COVID vaccine for children as soon as possible. Thank you.
Thank you very much for your comments. We'll move on to Ms. Elizabeth Ann Ditz. Ms. Dietz, are you on the line?
She is on the line, Dr. Lee. She may be having problems with her audio.
Okay, thank you. What we can do is we can move ahead to, and we'll come back to Ms. Dietz. Ms. Heather Brayton.
Can you hear me?
Yes, we can. Thank you.
Thank you for allowing me to speak today. I wrote different versions of my public comments because I did not know which groups you would qualify for additional vaccine doses. It seems that this is still being clarified, but that I will most likely qualify. I am a 44-year-old ovarian cancer survivor. Although I was grateful to receive my Pfizer vaccination this winter between cycles of chemotherapy, I was also worried because I knew chemotherapy blunts the effects of vaccines. I regretted that I could not wait until after treatment to get my shot. Over the past few months, I have become somewhat obsessive with reading news articles and medical studies. I have become so anxious because research showed that cancer patients like myself, who have solid tumors, only develop a fraction of the antibody titers, T cells, and B cells as healthy controls. I have felt distraught over the situation. My prognosis is poor. I most likely have about 2 to 3 years left to live. So every day counts. My life ambitions are humble. I want to be able to visit with vaccinated friends and family and not have to worry that I'll become a breakthrough case just because we took off our masks or got too close to each other or dared to actually spend some time inside. I'd like to go grocery shopping again and not panic and leave the store after 5 minutes. I'd love to travel because that's what people with a diagnosis like mine usually do before our health deteriorates. But the fear of catching COVID and knowing that I could become seriously ill and that approximately 10 to 30% of cases become COVID long haulers has kept me from being so bold. I don't think I could cope with both the side effects of cancer treatment and debilitating post-COVID symptoms. I'd like to thank the committee for including cancer patients like myself who have recently undergone chemotherapy for solid tumors to potentially receive additional doses of COVID vaccines. I'm not afraid of potential side effects of the third dose. While I understand I will still need to be cautious, I am hopeful for the peace of mind and greater freedom a third shot can provide. Thank you for listening.
Thank you very much for sharing your story. I'll see if Ms. Elizabeth Ann Ditz is on.
I am.
Thank you. Please go ahead.
Good morning. My name is Liz Dietz. Greetings, committee members and work group members. I am grateful for your tireless work over the last 18 months and in the time before COVID-19. Who am I? I have been advocating for high vaccine uptake in my community in San Mateo County for over 20 years. I'm a founding member of Vaccinate California, a grassroots volunteer advocacy group. I'm a longtime supporter of Voices for Vaccines, a national parent-led organization advocating for vaccine uptake. I'm a frequent contributor to a Facebook group called Vaccine Talk, an evidence-based discussion forum which has over 67,000 members worldwide. Over the last 4+ years, this group has helped 443 people move from being vaccine resistant to vaccine accepting. That's about one every 3.5 days. So fact-based social media is having a positive impact. I'm also over 65 with several risk factors for severe COVID if infected. I have been fully vaccinated for 153 days. Eventually, I might be in a group considered for a booster dose. I want to make 3 points. 1, over-reliance on vaccines as a way to end this pandemic. 2, global perspective on vaccine access. And 3, health equity in the U.S. First, I know you are all not the Advisory Committee on Non-Pharmaceutical Interventions for COVID Prevention, but I must say that the U.S.'s hyper-focus on immunization over NPIs has harmed our country's response to this crisis. As a nation, we must adopt all the tools at hand to tame this virus. Second, Gavin Yamey, MD, tweeted, "For the love of all that is good and holy, we need to recognize that we are a global community. There's a moral and ethical urgency to ensure that everyone worldwide has the same chance to benefit from the fruits of scientific progress, not just rich people." Finally, here in San Mateo County, we have a very high vaccination rate with noticeable holes. Many of our agricultural and hospitality industry workers are not yet vaccinated. But one friend learned. She was bringing in vaccine advocates who were native Spanish speakers. It turns out most of her employees, although from Mexico or Central American nations, were not native Spanish speakers and didn't really have health vocabulary in Spanish. They were native Nahuatl or Mixtec or other indigenous languages without health vocabulary in Spanish. So we need to fine-tune our efforts to increase vaccine uptake. Thank you very much.
Thank you very much for your comments. Ms. Pam Dixon?
Yes, thank you. Chair Lee and members of the committee, thank you for the opportunity to participate in the ACIP meeting today. I'm Pam Dixon, Executive Director of the World Privacy Forum, a public interest research group focused on privacy and data governance, including in the health sector. I have 2 brief points today. First, we support the CDC's prohibition on the use of vaccine recipient data for commercial marketing purposes. The CDC's vaccination program provider requirement, published in May of this year, specifically prohibits the commercial marketing use of COVID-19 vaccination registration information and the vaccine administration data. These prohibitions were warranted and are important for ensuring patient trust in the public health data ecosystem. I note that standard HIPAA rules already prohibit providers from using patient data for commercial purposes. There is now, after many years of HIPAA implementation, a reasonable expectation of some of the same levels of privacy in COVID-19 data ecosystems. Very few individuals understand the labyrinthine rules regarding HIPAA-covered ecosystems. Oh dear, HIPAA-covered ecosystems, and I'm sorry, I'm getting an emergency heat alert. Let me get back on track. Very few individuals understand the rules regarding HIPAA-covered ecosystems and public health ecosystems. And then second, we urge the committee to ensure that the same prohibitions that have already been put in place for commercial marketing uses of vaccine recipient data will also be required when the data is utilized in vaccine credentialing systems or proof of vaccination systems. We see significant potential risks for the commercial use of patient registration and patient vaccination data due to the sheer number of credentialing systems in development across complex public-private pathways. In conclusion, we support the work that the ACIP committee is doing to protect privacy interests and the integrity of public health data. We can all say a lot about how credential systems should operate, but this committee has the ability to make the most important statement of all about this ecosystem, which is to ensure that the data of those who have been vaccinated is fully protected in credentialing systems as well. Thank you very much for the opportunity to participate today. And my apologies for our emergency heat alert in Portland, Oregon. Thank you.
Thank you very much for your comments, and it's not a problem. We'll move on to our last public comment speaker, Mr. Edward Nierenberg.
Hello, and thank you for this time today. I'd like to call attention to several issues. To begin with, I do think it's important to offer consideration to heterologous boosting strategies. Immunogenicity data suggests superior responses from the combination of adenovirus vectors and mRNA vaccines, and preliminary effectiveness data suggests non-inferiority. Given, however, that the Sasanki study has just found 71% effectiveness of the Janssen vaccine against hospitalization, I would request that mRNA boosters be offered for recipients of Janssen, a vaccine that may have been favored in the first place by more vulnerable groups for whom access to vaccination may be an issue. Additionally, immunocompromised patients' infections are especially concerning for their public health implications because of the propensity for antibody escape variants of SARS-CoV-2. It may be worthwhile to consider prophylactic dosing of monoclonal antibody cocktails for those who have substantial humoral immunodeficiencies. Pregnancy is also an important high-risk state for COVID-19, and given that some individuals are becoming pregnant relatively far from their initial immunization, it may be worth considering additional doses during pregnancy both to bolster their protection and to provide passive immunity to their future children through transplacental neutralizing antibodies. I also think it's critical to remind everyone that we have a pretty grave situation with COVID-19 in the pediatric world. Since the beginning of the pandemic, in spite of aggressive mitigation measures in the U.S., approximately 500 children have died, tens to hundreds of thousands have been hospitalized, millions have been infected, and hundreds of thousands are additionally likely suffering from PASC. Furthermore, as was mentioned during the meeting, the AAP describes in a recent letter to the FDA that there has been a substantial rise in hospitalization among children recently, and I would urge everyone listening to do everything in their power to vaccinate their children against COVID-19 as quickly as possible. The call for a larger sample size by the FDA in clinical trials of children offers only marginal gains in the way of our pharmacovigilance, as sensitivity to detect rare adverse events, even with this change, would remain limited. But access to vaccination would be substantially delayed, and this is in the midst of a significant surge. The late sequelae of COVID-19 in children are presently unknowable. Measles causes SSPE only months to years after initial infection. This complication is both fatal and lacks treatment options. If COVID-19 causes anything analogous, we will not know for some time. A circumspect approach should dominate here, given the substantial costs incurred from threats to child safety and well-being at the public health scale. Lastly, I would request more frequent updates from VSafe and the Vaccine Safety Data Link if possible, as I think that having these references of vaccine safety for the public is extremely valuable. I would additionally like for stronger language regarding the recommendation to vaccinate recovered patients now that the clinical benefits of doing so have been ascertained in addition to the immunological ones. Thank you very much.
Thank you very much for your comments. And with that, our public comment session has ended, and I would like us to move on to the vote and discussion on the topic of additional doses of mRNA COVID-19 vaccines as part of a primary series. Dr. Dooling, would you be willing to put up the proposed language for the recommendation?
Yes, thank you, Dr. Lee. So to revisit the policy question that's in front of ACIP, should vaccination with an additional dose of Pfizer-BioNTech COVID vaccine in those 12 and older, or Moderna COVID-19 vaccine in those 18 years of age and older, be recommended following a primary series in immunocompromised people under an emergency use authorization? Next slide. And to recap, the work group determinations were that the desirable consequences clearly outweighed undesirable consequences in most settings, and they supported we recommend the intervention recommendation. Next slide. So the vote language here in front of you is that an additional dose of Pfizer-BioNTech COVID-19 vaccine for those 12 and older, or Moderna COVID-19 vaccine for those 18 years of age and older, is recommended following a primary series in immunocompromised people. Thank you. I'll turn it back over to you, Dr. Lee.
Thank you. I will break this up into two sections. I would request that that any of our voting members can make a motion on this interim recommendation, and then we will move to a discussion around this. So if there's any clarifications that are needed from ACIP members on the wording of this, please chime in now, but otherwise I'd like to move forward with a motion. Dr. Chen?
Forgive me if this is already known within the work group, but I believe that Moderna did submit to the FDA for the adolescent indication in June, and I don't know if there is a projected timeline for when that determination may be made by the FDA, but I just wonder if this language that we have presently for Moderna and the 18 years will need to be then quickly revised in response to that potential EUA authorization extension for the Moderna product. And so if it's expected to be soon, then would we have the ability to have flexibility in this language to really suggest for the ages that it is authorized rather than those specific ages, or is that not allowable? Because again, we are only able to make the recommendation on present EUA authorization. Well, in there.
Hi, this is Dr. Dooling. I think the intent today is to proceed with the maximum specificity we can under the emergency use authorizations as they stand today. If there are additional products or expanded EUA in the future, we will certainly come back to the ACIP with any modifications at that time.
Thank you for the question and the clarification. Dr. Alt?
I move that we accept the language on the slide for a vote.
Thank you, Dr. Alt. Dr. Paling?
So, Dr. Lee, that was the motion. So, are you looking for a second?
I'm sorry. I found my unmute button. I was seconding that motion, please.
Thank you. Okay, terrific. So it's moved and seconded that we adopt the recommendation language presented by the work group here on this slide. Before we move to a vote, I'll invite our voting members to discuss the motion on the table and ask if there's any additional questions or issues the committee would like to discuss before the vote. I see Dr. Alt's hand is up. Go ahead.
Well, I actually had the same question that Dr. Chen did. I just wanted to make the motion first. So what's the mechanism for us coming back and rewording this? Will we have to have another meeting, or that just happen automatically specific to the Moderna vaccine?
So, Dr. Alt, this is Amanda. To clarify, so as soon as if and when there is FDA authorizes the Moderna vaccine down to a different age group, we will have a meeting to review that data and to vote both for all kids down to that age group to be able to receive Moderna, and we will revise this at that time. We don't yet have a timeline for that, but under the EUA, we're wanting to make sure we're very careful to vote for each change, even if just to make sure that we're recommending things under the EUA. So yeah, we'll come back as soon as that Moderna EUA is authorized.
That makes perfect sense. Thank you.
Thank you. Ms. Batra?
Thank you, Dr. Lee. I just wanted to weigh in here that I am really grateful that we finally have an expanded EUA, particularly for the immunocompromised, so that we can provide more protection for those who may not have responded initially. And I really think that this is overdue, but we're working as fast as we can. I do acknowledge that. And also wanted to urge clear communication about who this for, why it's an additional dose, not a booster dose, because those kinds of things are already in the general public arena as a very confused concept. Thank you.
Thank you. Would any other ACIP members like to comment on this particular motion that's on the table? Oh, Ms. McNally, please go ahead.
Thank you. Dr. Lee or someone at the CDC, can you confirm for me that the information for the public will be clear regarding the mRNA distinction versus the J&J vaccine as not being an eligible option? Thank you.
Yes, this is Amanda. So the language in the clinical considerations, which I know is meant for providers, indicates that at this time there are no data to support use of an additional dose of mRNA vaccine after the J&J vaccine, but we are working as fast as we can, and we anticipate that we will soon have data that will help support that or be able to offer that. All of these recommendations, and thanks, Ms. McNally, for bringing this up because we've talked about this a lot. We will have a communications package for both healthcare providers and the public to make sure that people understand both if they're in this group, who needs booster doses or additional doses, and who doesn't. And we are working on those materials and will adapt them according to the discussions today. But there will be both provider materials and materials for the public, similar to what we've done with some of the recent warnings. Thank you.
Thank you. And I just want to highlight how incredible the CDC staff have been in really putting together these education and communication materials, which is an incredible challenge under changing context, changing data, evolving data. And so, just kudos for doing a phenomenal job. We recognize it's not easy, and the demands on your team have been tremendous during this COVID-19 pandemic in many directions. So, but we appreciate that you continue to prioritize communication as a key component of what we need to do to implement our recommendations. I'll turn it over to Dr. Cotton.
Thanks. I would definitely like to second that with all the hard work done by the CDC and really following the science and, being adaptable to things as they evolved. And all of us are very appreciative of that for sure, especially from CDC and other FDA leadership, et cetera. I just have a nuts and bolts question. So I am getting a tremendous amount of messaging across the board from patients and leadership in my own healthcare system. It seems like as soon as this meeting ends, there may be many people that go ahead and go get themselves vaccinated at a variety of places. Is there anything further that you will be, you'll provide us guidance? Do we have any idea for time frame? It's kind of just really the nuts and bolts of this rollout, because I'm sort of suspicious that many people who are more than a month out from their second dose of vaccine will be going out this weekend to get themselves another dose. Just wondering if there's anything more, any guidance.
Thanks, Dr. Cotton. Yeah, we will have, we are working as we speak to update the clinical guidance based on the feedback and input that you provided. And we anticipate, if this vote passes, that we will publish that updated clinical guidance sometime late afternoon or evening. We're also having partner calls that we will share this information with today. We anticipate having a COCA call early next week, and we have been working, over the last 24 hours, maybe 48, with pharmacy groups and with our jurisdictions to prepare for implementation of this recommendation. So we're hopeful that this will be rapidly implemented.
Thank you. Can I just ask you, when they go to a pharmacy, are people going to be asked, screened in any way, or is it kind of an anticipated honor code approach?
So it's typically when somebody goes to a pharmacy, there's typically several questions that they ask to make sure they don't have any contraindications. And I can't speak on behalf of the pharmacy groups, but they may manage this differently, but they'll likely just say, do you have a moderate or severe immunocompromising condition or something like that? But it will be a patient's attestation. And there will be no requirement for proof or prescription or a recommendation from an individual's healthcare provider.
Thank you very much.
Thank you. I do not see any additional ACIP member hands raised. Oh, I do. Dr. Sanchez, go ahead.
Sorry, thank you. I just didn't realize I had taken it down. A couple of things. First of all, I just wanted, will Be Safe be amended to include that this is a third dose? I'm not sure if that was discussed, or because obviously we really want enhanced surveillance. So I don't know what if Be Safe is, if there is already an option or not for multiple doses. So that's my first question. And then I just really think that we do need to provide some guidance. I know that we don't have the data on those individuals who received the Janssen product and then followed by messenger RNA, but that I'm sure will, I mean, I think CDC must comment on this, because similar to the fact that already people have received the third dose, immunocompromised individuals have received third doses even before this meeting. I really feel that we need to comment on a messenger RNA vaccine after the Janssen project, because it's happening, and personally, I am in favor of that happening as well. Thank you.
Thanks, Dr. Sanchez. This is Amanda. So absolutely, VSafe is being updated. I don't know if anybody from the Immunization Safety Office can provide us with an update of when that third dose is. Dr. Broder, can you give us an update on?
Sure. This is Karen Broder from the Immunization Safety Office, and VSafe is being updated to be able to capture information about dose 3 for both new registrants as well as those who previously have entered doses. Those updates are in testing now with the goal of trying to launch this weekend or no later than early next week, and information will be available on the web as well. And thank you for using VSafe, and thank you for the question.
Thanks, Dr. Broder. In response to your second comment, Dr. Sanchez, thank you. I mean, we totally agree. There's actually are studies that are being done with the J&J vaccine and then an mRNA vaccine, and we anticipate having some data from that very, very shortly. So we do think that this is going to be a very short-lived, we're hoping for it to be a very short-lived challenging issue, but we will work as hard as we can to be able to address this adequately and appropriately. But we do understand that it's happening.
Thank you. I see 2 more hands raised, and then hopefully we can move on to vote unless there are any other questions or comments that our ACIP members would like to make. Ms. Stinchfield?
Yes, thank you so much, Dr. Lee, and all the presenters today. I support the vote as noted here. As clinicians and health systems, what we will do from here is turn to our electronic health records and try to poll the patients who meet this requirement and communicate with them directly. And so as specific and clear as you can be in the clinical guidance, things that we can pull, coded diagnosis, specific drugs, medication names, et cetera, that will be very helpful to a tired group of clinicians out in the field. Immunosuppressive therapies and severe primary immune deficiencies are too broad of terms to be useful in an EHR. So thank you for that consideration.
Thank you. And Dr. Shaw?
Thanks, Dr. Lee. Just a few observations. The first, and this is very much in keeping with Ms. Stinchfield's comments. I note that the FDA's EUA expanded the ambit of the mRNA vaccines for those who have undergone solid organ transplantation or who have been diagnosed with conditions that are considered to have an equivalent level of immunocompromise. Even in the discussion today, what's been discussed is moderate to severe, but the motion on the table is a broader swath of what appears to be all immunocompromised. And so I'll defer to you as the chair about whether there's wisdom in amending the language to reflect following a primary series in those who have moderate or severe immunocompromise or something of that nature. Otherwise, some of the concerns that many commenters have noted around patients knowing whether they are eligible, they may read the EUA and find themselves to be ineligible because of the higher bar, but then read the motion on the table from ACIP and think that they are eligible, and that would create a fair degree of confusion. So that's one observation and potential avenue there. Two others, or three others, very quickly. I can imagine questions arising about whether there is a date beyond which the additional dose would not have immunological efficacy. So I know that it's at least 28 days, but as has been noted, many individuals in this category would have been vaccinated 5-6 months ago. And there may be questions about whether if I finish my dose series 120 or 180 days before now, will this third dose get me where I need to be, or should I repeat the entire series? I know that's not under discussion right now, but it could be something for inclusion in the clinical criteria. Similarly, in the discussion that's published, there will be some interesting questions that states will have to grapple with. From a regulatory perspective, for example, are the 2.7% of the population that would be subject to this, are they no longer considered fully vaccinated until they get this third dose? That has an implication down the road. Similarly, if someone who is within that 28 days, if they get COVID, are they a breakthrough case now? So on and so forth. Those are some downstream considerations that states have already been talking about and thinking through that I wanted to offer. Thank you.
Thank you for the pragmatic, real-world questions we have to face. I'm going to actually ask Ms. Coyle to state her comment, and then I'll ask our Dr. Dooling if she can respond to the collective comments.
Great, thank you. This is Rebecca Coyle, and I'm with the American Immunization Registry Association. And I think one thing I just want to sort of point out here is that we're sort of dipping into a new concept that really hasn't, I think, emerged before, and that's the idea of adding to a primary series. And while I think that's fine from a clinical perspective, I do think it's important to recognize the technology component of this, and particularly the clinical decision support capabilities of, I think, both EHRs and immunization registries. So one, on the immunization registry side, I think it's going to be important to note that immunocompromise is a very broad category, and most IS are not going to have the ability to identify individuals that would fall within this category because of the types of risk factors. And this will really be, I think, where EHRs and IS really have to work together there. And then I think the other important piece is whether a series is determined as complete. A lot of EHRs and IS will indicate that, following the primary series that it's complete and may recommend a booster dose. As we start getting into considering booster doses, when you now have a series complete at either 2 doses or 3 doses, how the booster doses may be reflected is going to be challenging, I think, for all systems. So just a couple comments, I think, to file away. Thank you.
Thank you for your comments. And I'll ask if Dr. Dooling or another colleague from the CDC would like to just add any comments or clarification to the discussion.
Hi there. Thanks, Dr. Lee. To respond to a couple of those points that were raised, this recommendation is for moderately and severely immunocompromised people, which is very clearly spelled out with specific reference to conditions that would constitute that category in the clinical considerations document that will be posted on the CDC website. Again, our intention is as soon after the vote as is humanly possible. I fully support all of the statements that were made about registries' ability to collect a third dose. That is certainly in place, and agree that the more that we can link electronic medical records to add that specificity around immunocompromise, we should definitely be working towards that. So that, I'll turn it back to you, Dr. Lee.
Thank you. Yes, and I personally, my opinion, I concur that I think it makes sense, just similar to what we've done before we provide a lot of clarity in what the intent of the recommendation is, but that adding too much specificity to the recommendation can be challenging. And I think the immunocompromised population is a special population that in and of itself, defining that cleanly is challenging. So allowing clinicians to be able to weigh in on that, I think, is really important for that individual benefit risk discussion. Dr. Sanchez?
Thank you. And actually, the previous person, it brings up an important point, because as we're seeing vaccine mandates both at the, at all levels of society, are we going to be considering immunocompromised individuals as requiring 3 doses, or is a 2-dose series sufficient to say that they are vaccinated? I think some clarification of that will be important as well.
Hi, this is Dr. Dooling again, if I can respond to that, a really important point. For the purposes of meeting the definition of fully vaccinated, it is 2 doses of mRNA vaccine or 1 dose of Janssen. That has not changed, and that will also be very explicitly spelled out in the clinical considerations.
Thank you.
Thank you. I do not see any additional hands that are raised, so I will assume that the committee is ready for a vote on the motion. Are there any objections to proceeding with the vote?
No, I think you can proceed with the vote, Dr. Lee.
Okay, terrific.
So we're going to ask, thanks, Dr. Alt, for everyone to put their video on to prepare for the vote. And once again, I know a lot of you have expressed your opinions. So if you do have a brief comment after the vote you'd like to make, that's great. But let's go through the vote first. And Dr. Lee, do you have the list of members to call out?
I do. So ACIP members, I'll ask you to state your name, whether you have a conflict of interest, and then your vote on the proposed interim recommendation that is shown on the screen there. We'll start with Dr. Long.
Sarah Long, no conflict, yes.
Ms. McNally.
McNally, no conflicts, yes.
Dr. Paling.
Paling, no conflict, yes.
Dr. Sanchez.
Pablo Sanchez, no conflict, yes.
Dr. Talbot.
Kip Talbot, no conflict, yes.
Dr. Alt.
Alt, no conflicts, yes.
Ms. Bata.
Bata, no conflicts, yes.
Dr. Chen.
Chen, no conflicts, yes.
Dr. Daly.
Can you come back to, oh.
Matt Daly, no conflicts, yes.
Dr. Cotton.
Camille Cotton, no conflicts, yes.
And I'll call on myself, Grace Lee, no conflicts, yes. So I believe we have, I'm calculating correctly, Dr. Cohn, 11 yeses, 0 nos, and the ayes have it, and the recommendation is adopted.
Yes, I have the same thing. The motion passes.
Terrific, thank you. And I will ask if individuals would like to comment about their vote or make any additional, have any additional clarification. So Dr. Talbot, I see your hand.
Yeah, I just wanted to say how much I appreciated that ACIP and the work group and the CDC have really delineated the idea of a 3rd dose in a series, for a primary series, versus a booster. I think that's incredibly important. I think we're looking at a very specific population in the U.S. that was not able to mount an appropriate immune response to the normal 2 doses. And so this is a very specific population and is not meant for the entire U.S. population. We are all very worried about the Delta variant, but that may be the least of our problems if COVID-19 continues to circulate across the U.S. and the world. And so I think it's incredibly important that we remember that we need to begin sharing more and more vaccines across the world and encouraging those pockets of low vaccination rates to immunize, or the Delta variant may be the least of our concerns. So just as a reminder, thank you.
Thank you. Dr. Paling, would you like to make a comment?
Yes, this is Kathy Paling. Can you hear me?
We can, thank you.
Okay, good. So thank you. I do want to express my sincere thanks to everybody at the ACIP, the working group, and the FDA for making this data available so we could have this vote. I voted yes for an additional dose of mRNA vaccine for all children and adults over 12 years of age with moderate and severe immunocompromising conditions to maximize their chance of protection from vaccine. These persons have increased risk of hospitalization, breakthrough disease, and death from COVID-19. In addition, the vaccine effectiveness among immunocompromised is lower than those without immunocompromising conditions. Recent studies demonstrate that 33 to 50% of persons with immunocompromising conditions who did not initially respond did respond with a third dose in the primary series. This vote enables all persons 12 and older to obtain a third dose in a primary care series to increase their protection from vaccine. It is critical to highlight persons with immunocompromising conditions and their families, the importance of wearing masks, maintaining social distance, and avoiding crowded locations indoors, and cocooning by having close contacts vaccinated. It's equally important to share and highlight the importance that all schools create plans so that all children, including those with moderate to severe immunocompromising conditions, can safely attend school. Thank you.
Thank you. Are there any other members who wish to state their opinion? Okay. With that, I'll just thank everybody for the vote and the robust discussion that happened today. And the committee will now recess for 4 minutes, so 55 after the hour, and we'll reconvene. Thank you. Okay, Dr. Cohn, are you there?
Dr. Cohn just stepped out, but I think we're ready to go ahead and get started again. Thanks.
Okay, great. Thanks, Dr. Peniel. I want to be mindful of time, and I recognize we're running behind. So we will now reconvene the meeting to hear our updates from our CDC colleagues. We'll first have Dr. Heather Scobie present an update on emerging SARS-CoV-2 variants and COVID-19 vaccines. And then Dr. Sarah Oliver will present on considerations for booster use of COVID-19 vaccines for the future. So Dr. Scobie.
Good afternoon. Next slide. Next slide.
Would you get a little closer to the mic, Dr. Scobie?
Sure. Is this okay?
You're a little quiet, but I think if you speak loudly, it'll come through.
Maybe
Thank you.
Is this one better?
Yes, much better. Thank you.
This slide shows one of the new ways that CDC is visualizing the impact of COVID vaccination on the COVID data tracker website. The graphs display weekly trends by age group for the cumulative percent of people fully vaccinated in blue and the average rate of new cases per 100,000 population in gray. The three graphs at the bottom in the red box represent the three age groups greater than 50 years of age. Here we observe higher coverage rates and lower case rates compared with the younger age groups shown above that have lower coverage and recent increases in cases. Next slide. This map, also from COVID Data Tracker, shows a county-level view of the case rates per 100,000 population over the past 7 days compared with vaccination coverage rates. A legend is shown on the right. The magenta and purple colors that predominate the map are counties with low vaccination coverage and high recent COVID incidence. The green and light blue colors are counties with higher coverage and low COVID incidence. Counties colored navy blue, which represents greater than 50% coverage and high incidence, are relatively few and reflect the recent increases in Delta variant transmission occurring largely among unvaccinated persons. Next slide. A lot of public concern has been raised on the Delta variant and breakthrough transmission, which I'd like to try and contextualize with two example state scenarios, each with 1 million population and different coverage levels. State A has 70% coverage on the left, and State B has 30% coverage on the right. The COVID data used for this example are actual data from the COVID Data Tracker website for states with similar coverage levels. The dots each represent 10 COVID cases, and in State A, 130 cases are occurring per week, compared with over 5,000 cases occurring weekly in State B. Using the vaccine efficacy estimates from the UK, we can estimate the number and proportion of vaccinated cases shown in red and vaccinated cases shown in blue. Proportionally, there are more vaccinated cases in State A at 22% of cases vaccinated, compared with just 5% in State B. But this is expected because the proportion of cases vaccinated increases with increasing vaccination coverage. At the extreme of 100% vaccination coverage, all cases would be vaccinated because no vaccine is 100% effective. Next slide. Similar trends with hospitalization are observed below, where 1 dot equals 1 hospitalization. In State A, just 1.4 hospitalizations occur weekly, and in State B, 18.8 hospitalizations occur. In both states, the majority of cases and hospitalizations are among unvaccinated people. Next slide. Next slide. 4 variants are considered variants of concern. Alpha or B117 first detected in the UK, Beta or B1351 first detected in South Africa, Gamma or P1 first detected in Brazil and Japan, and finally Delta or B1617.2 first detected in India. Attributes of the variants related to public health impact are noted in the table. Of note, all of the variants of concern have mutations in the receptor binding domain that have variably impacted vaccine efficacy, with the cluster of mutations shared by beta and gamma having the largest known impact. Another class of variants under monitoring are the variants of interest, which have similar mutations but less current evidence of public health impact. Next slide. These are our latest national nowcast projections of the proportions of circulating SARS-CoV-2 variants from CDC's COVID data tracker. The stacked bars show the observed historic estimates and the most recent nowcast projections for the commonly sequenced SARS-CoV-2 lineages in the US by 2-week interval of specimen collection date. The variants of concern depicted in different orange shades have increased over time. In projections for the 2 weeks ending July 31st, alpha decreased to a projected prevalence of 2%, gamma decreased to 1%, and beta remained at 0%, while the delta variant increased to 94%. Recently, the graph was changed to display the different delta sublineages, and AY3 has increased to 13%. This sublineage does not contain the so-called delta plus mutation. Next slide. We have several types of evidence that we monitor to assess the impact of variants on vaccines, including antibody neutralization generated in the laboratory. Though we note that a correlate of protection is not yet established, good correlation has been observed between vaccine efficacy and the neutralizing antibody levels from different vaccines, and this will likely be the first type of evidence we get on the impact of new variants on vaccines. We also monitor vaccine efficacy data from clinical trials and real-world vaccine effectiveness studies. We note that a greater proportion is usually observed against severe disease, or greater protection is usually observed against severe disease than symptomatic illness, and confirmed infection, which includes asymptomatic cases. And this is because protection against severe disease requires lower antibody levels and is less affected by differences in efficacy across vaccines. Finally, we monitor vaccine breakthrough infection, and I'm going to review these types of evidence now. Next slide. We conduct a review of available studies on vaccines authorized or intending to be authorized in the US and containing data on the ability of post-vaccination sera to neutralize SARS-CoV-2 variants. In this dot plot, the reduction in neutralization of the variants is shown relative to the wild type or dominant strain used in each study, where no effect equals 1 at the bottom of the y-axis. Each dot represents one study result, with mRNA results shown together in blue, AstraZeneca in yellow, Novavax in brown, and Janssen in green. Beta had the largest median reduction at 7.5-fold, Delta had a median reduction of 2.8-fold, Gamma was reduced 3.1-fold, and Alpha was reduced 1.9-fold. While an Alpha variant with an E484K change, which has been detected in the UK, US, and other countries, had a further reduction in neutralization compared to Alpha alone. Next slide. In terms of what is known about duration of immunity, to date, available data demonstrate antibody persistence for at least 8 months after COVID infection and at least 6 months after the second mRNA vaccine dose, with some evidence at 8 months for the Janssen vaccine. Studies suggest individuals may maintain long-term protection from severe illness caused by antigenically similar strains, even if they become susceptible to mild infection. 2 studies have shown a combined impact of waning antibody levels and reduced neutralization of variants. At 6 months after receiving the Moderna vaccine, neutralizing antibody levels were reduced but sufficient to protect against the ancestral strain, while about 50% of people had undetectable neutralizing titers against the beta and gamma variants. A small study at 8 months after receipt of the Janssen vaccine observed minimal decline in neutralizing titers and improved protection against beta, gamma, and delta variants compared with 1 month after vaccination, which was suggested to be related to antibody maturation. It's unclear if there are differences in the kinetics of antibody response by vaccine platform, and more data is needed. Next slide. Pfizer recently published their 6-month clinical efficacy data. Vaccine efficacy, or VE, against infection out to 6 months was 91%. They performed an additional analysis looking at different time intervals after receiving the second vaccine dose and observed a gradual decline in VE against infection of 6 percentage points every 2 months, though the confidence intervals around the estimates were overlapping. At 4 to 6 months post-vaccination, VE was 84% compared with 96% at less than 2 months after vaccination. VE against severe illness during the period was 97%. Moderna has not yet published their extended efficacy results, but announced in a press release that VE was 93% for up to 6 months. Next slide. In terms of VE against the variants, for the Alpha variant, mRNA vaccines have been shown to have greater than 85% real-world VE against confirmed infection in the US and multiple countries. For Gamma, mRNA vaccines had 84% to 88% real-world VE against symptomatic infection and 79% VE against confirmed infection when Gamma was widely circulating in Canada. For Beta, Moderna vaccine had 96% real-world VE, and Pfizer vaccine had 75% VE against confirmed infection in a study from Qatar, while Janssen vaccine had 52% VE against moderate or severe disease in their clinical trial in South Africa. Importantly, all studies observed high VE against severe disease. Next slide. In terms of what we know about the Delta variant, it's nearly twice as contagious as previous variants. There is some evidence of increased illness severity compared with previous strains in unvaccinated persons. The greatest risk of transmission is still among unvaccinated people, and fully vaccinated people with Delta breakthrough infections can spread virus to others. However, when vaccinated people with Delta may be infectious for shorter periods than unvaccinated persons with Delta. Next slide. For the Delta variant, vaccine effectiveness studies have been published from several countries, mostly for the Pfizer vaccine. In England and Scotland, reduced Pfizer VE was observed at 79% for infection and 88% for illness compared to 92 and 93% for the Alpha variant. Protection against hospitalization from Delta was 96%, which was similar to that observed with Alpha. In Canada, Delta VE estimates were similar to the UK, but with smaller differences in VE for Alpha and Delta. Israel has observed a progressive decline in VE during the period after Delta predominance, with the most recent VE estimates of around 40% against infection and illness, while VE against severe disease has remained above 90%. Qatar was the only country that assessed Delta VE for both Pfizer and Moderna, shown with hollow symbols. VE against symptomatic illness was 54% for Pfizer, compared with 85% for the Moderna vaccine, while VEs against severe illness were above 90% for both. It's important to note that the comparisons shown for the Alpha and Delta VE in Israel and Qatar are for different studies that were separated by 2 to 5 months during the time periods when Alpha and Delta circulated. Other methodologic differences may explain some of the variation observed in the study results across countries. Next slide. Other potential differences in VE results relate to differences in the vaccine programs by country. In the US, we use the Pfizer, Moderna, and Janssen vaccines, which have followed the manufacturer-recommended intervals of 3 and 4 weeks between mRNA doses. Israel has also used Pfizer vaccine, and has only used Pfizer vaccine, though they also authorized Moderna, and followed the 3-week interval between doses. Israel also had a very tight cohort with more than 50% of the country vaccinated in the first 3 to 4 months. Qatar is the most similar country to the US in terms of using both Moderna and Pfizer at the same dosing intervals. Finally, the UK and Canada are the most similar to each other in that they both use mRNA and the AstraZeneca vaccines. As part of a dose-sparing strategy, they also adopted extended dose intervals of up to 12 to 16 weeks, which were later shown to improve immunogenicity in VE compared with standard intervals, including for ages greater than 80 years. The countries also support mixing and matching between vaccines, which has been shown to increase VE. I'll also note that the Pfizer vaccine has a lower mRNA dosage an accelerated schedule of 3 weeks compared to 4 weeks for Moderna, which has the potential to impact the robustness and duration of immunity, as has been generally observed for other vaccines. Next slide. In public data from Israel, the Ministry of Health has observed higher breakthrough rates and lower Pfizer VE against infection for persons vaccinated during January to February than in more recent months for persons aged 16 to 59 and 60 years and older. 2 retrospective cohort studies of persons vaccinated with Pfizer in large healthcare systems observed increasing breakthrough infections among persons vaccinated in January versus April, and higher breakthrough infection rates among those who received the second mRNA dose more than 5 months ago compared with less than 5 months ago. All age groups were impacted, but one study observed higher magnitude of differences with increasing age. Next slide. Delta only rose to predominance in the US at the end of June. This week, the first study assessing potential VE changes in July was posted from the Mayo Clinic healthcare system. For patients in Minnesota, the authors observed that VE against infection was significantly lower for both Moderna and Pfizer vaccines in July, when Delta variant was more than 70% prevalent compared with previous months, and significantly lower for Pfizer at 42% compared with Moderna at 76%. Importantly, the effectiveness of both vaccines against COVID-associated hospitalization remained consistently high during the same time frame. More information is needed in this area and will be forthcoming. Next slide. Despite high efficacy, vaccine breakthrough cases are still expected to occur, including those caused by circulating variants. CDC conducts nationwide monitoring of vaccine breakthrough cases resulting in hospitalization or death. As of August 2nd, among more than 164 million fully vaccinated in the US, there have been 7,101 hospitalizations and 1,507 deaths with vaccine breakthrough reported to passive surveillance. Among hospitalized or fatal breakthrough cases, 75% were 65 years or older. In addition to national passive surveillance, CDC has a number of other ways to monitor breakthrough infection, including a population-based surveillance system called COVIDNet, which represents 10% of the US population. The most recent COVIDNet data on COVID-associated hospitalizations among adults estimated 32% of all vaccinated cases are immunocompromised versus 11% of unvaccinated cases. Next slide. To summarize, Alpha, Beta, and Gamma variant have low prevalence in the US. Alpha has minimal impact on VE, while Beta and Gamma have moderate impact, though the vaccines appear likely to protect against severe disease. Delta has high prevalence in the US and has moderate impact on vaccine effectiveness, though the vaccines are likely to still provide protection against severe disease. More data is still needed on the impact of Delta, especially for the Janssen vaccine and the potential for waning immunity. Next slide. Manufacturers are conducting booster studies of current vaccines and or second-generation vaccines against the Beta variant. Moderna has posted preliminary results of a phase 2 trial of a single booster dose of the previously authorized and a Beta variant-specific vaccine. Both vaccines had acceptable safety and it boosted immunity to the wild-type strain as well as to the Beta and Gamma variants. Pfizer has also submitted preliminary data on a booster of their original vaccine to the FDA. No Delta-specific booster vaccines have been shared to date, or studies have been shared to date. In summary, next slide. In summary, the currently authorized vaccines work against known variants. Given the increased risks related to the Delta variant, it is important to increase vaccine uptake in all eligible populations. CDC is closely monitoring real-world vaccine effectiveness and breakthrough infections using multiple methods, populations, and outcomes. CDC continues to monitor emerging variants, including their prevalence and impact on disease incidence, severity, and vaccine breakthrough. The ACIP will review evidence submitted for boosters and any next-generation vaccines to address the evidence of diminished VE related to the variants or waning immunity. Finally, this is a changing landscape, and CDC will continue to communicate promptly about emerging evidence. Thank you.
Thank you, Dr. Scobie. And this presentation is now open for questions. Ms. Bata.
Thank you. And thank you for this thorough presentation. I really appreciate the information you've provided today. I'm wondering if we could go to slide 20. I think I need some clarification about the last bullet, that 32% of all vaccinated cases are immunocompromised versus 11% of unvaccinated who are immunocompromised. Can you please explain that to me?
Sure. It means that by vaccination status, there are differences in the way the cases look, I guess. So just like breakthrough cases, fatal breakthrough cases, would occur in older persons, as is summarized. For immunocompromised people, there's a larger proportion of, for breakthrough cases, there's a larger proportion of immunocompromised immunocompromised persons compared with unvaccinated cases. I'm not sure if that's clear, but there are differences in the background characteristics of cases that are vaccinated versus those that are unvaccinated. Is that clear?
Thank you. Thank you. Dr. Arthur?
Thank you, Dr. Lee. I really liked the slide at the beginning that shows the variation in ages and immunization rates by age and how that's affecting the case counts by age. I wondered if the CDC had intended to do the same analysis by race and ethnicity. I think that in terms of understanding the overlapping pockets of unvaccinated persons, the age category is just one part of the problem, and understanding how race and ethnicity are affecting both vaccination levels and case count would be extremely helpful. I think that was a great slide. I'd love to see it broken down by a couple of other factors. Yes, this slide here. Thank you.
Thank you.
Thank you. Our CDC colleagues will take that under advisement. Dr. Freihofer?
Sandra Freihofer, American Medical Association. Thank you for that excellent presentation. Could you take a look at slide 9? You briefly mentioned the Delta plus variant, but I sort of missed what you said, and this is something I get a lot of questions about.
Sure. So
the Delta plus variant.
The Delta plus variant, it's not a name we actually use, but it does correspond to what you see as AY1 and AY2 on this slide. So AY3 does not have the mutation that the media refers to as Delta plus. Is that clear?
Thank you so much. And on slide 16, can you say again what the open circle meant under the Qatar? It's an open blue circle.
Yeah, so do you see the bands under the country labels for Pfizer and Moderna? This slide was hard to create without making it look overly busy, so only the 2 results on the right relate to Moderna. The rest relate to Pfizer. And that's...
Thank you so much.
Thank you. Dr. Maldonado?
Yes, thank you. That was a great presentation. I have a question about the Mayo study. I have reviewed the manuscript, the preprint, but I'm still a little confused about the statistical methods that were used to calculate effectiveness, and I wondered if you could provide some clarity. They used an interesting approach, which is they used matched triples, so an unvaccinated, vaccinated with Pfizer, and vaccinated with Moderna. But the thing that I'm concerned about, or at least want more your input on, is they actually included people who would receive, their whole cohort included single vaccinations as well as fully vaccinated individuals, but I couldn't really determine whether they calculated effectiveness based on breakthrough infections after all one or more doses or just after 2 doses. And that, I think, would affect effectiveness. I don't know why it would skew by product, but certainly that could affect effectiveness as well. So just wondered if you have any additional information about whether they, in fact, included just fully vaccinated or not. It looks like they included all, even single-dose vaccinated individuals.
Thanks. So that paper is still, it's a preprint. It's still under peer review. So let's hope that if it's not clear, it's clarified for the final publication. I don't have any additional information beyond what's included in the preprint. And we're looking forward to, results that should be released from CDC studies in the coming weeks.
Thank you. Ms. Leger?
Hi, thank you. Thank you for your presentation. On slide 12, addressing duration of immunity, do you have any data about individuals who've had the vaccine and COVID-19 infection as far as how long their immunity antibody persistence lasted? I guess the question is your immunity additive if you've had both natural infection and vaccine?
Yeah, thank you. There are quite a few studies published on this topic, and the consensus appears to be that having a previous infection and then being vaccinated probably provides the best immunity compared to just getting just being infected or just being vaccinated. It boosts immunity levels to high levels and has greater protection against variants because of maturation of the immune response. But I'm not sure about the duration of protection and whether there's information available on those individuals related to the question you asked.
Thank you.
Thank you. I see no new questions, so I wonder if we can move on to Dr. Oliver's presentation.
Great, thank you so much. Next slide. So as we think through recommendations for booster doses of COVID-19 vaccines, the main question we're answering is, are booster doses needed for those previously vaccinated with the primary series? As with other things with COVID vaccines, policies on boosters will be coordinated with FDA for regulatory allowance and ACIP for recommendations around use in specific populations. Next slide. Then we want to continue to distinguish that an additional COVID-19 dose after receipt of a primary series is one way to provide protection for those who may not have mounted an appropriate immune response to the initially recommended series. This is not considered a booster dose, and this is what was described for the first part of the meeting. What we're talking about now are booster doses, which are vaccine doses administered when the initial sufficient immune response to a primary series may have waned over time after a primary series and then can increase immunity. Next slide. So from this point on in the presentation, we'll be focusing on booster doses. Next slide. So recommendations for booster doses would obviously only apply to those who have completed a primary series. To date, over 350 million vaccine doses have been administered in the US. The figure on the left shows the number of people fully vaccinated by COVID vaccine series type. And then on the right shows percent of the population fully vaccinated by age. Over 60% of those 18 years of age and over are fully vaccinated, and this increases to over 80% among those 65 years of age and over. Next slide. So the timing of when individuals became fully vaccinated is important to this discussion as well. This figure shows the daily count of fully vaccinated people with the 7-day moving average shown in red. As everyone will recall, we began the COVID vaccination program in December of 2020. As only 2-dose series were available at that time, we began to see individuals become fully vaccinated in January. Then through spring, we increased vaccination rates, where between 1 and 2 million individuals were fully vaccinated each day. Then through the past month, we've been adding around 200,000 fully vaccinated individuals each day. Next slide. However, we know that due to the way the vaccine was recommended and rolled out initially, age groups are not evenly distributed across the last 8 months. When we look at the weekly count of fully vaccinated people in the US by age group, you can see that those 65 years of age and over, in yellow, were among the earliest vaccinated. In the spring, we then moved into larger populations of those 18 to 39 in lavender and 40 to 64 in gray. And then recently, since vaccination was recommended for adolescents, you can see the 12 to 17-year-old population in black. This varying age distribution will be important as we think through recommendations for boosters in a variety of populations and ages. Next slide. So this is the plan for how ACIP will approach booster doses over the next several weeks. We need to think through what are the key considerations for decision making. Then we evaluate what data are available for decision making. And finally, then we can address, does ACIP recommend booster doses for COVID vaccines in any populations? Next slide. For today's presentation, we'll focus on what are the key considerations for decision making. Next slide. At the ACIP meeting in June, we laid out data that would be needed to inform recommendations for booster doses, thinking through the risk of COVID complications and exposures, risk of waning immunity, and risk of COVID variants. Next slide. As we move into preparations for a possible vote in the future, we're restructuring the questions slightly, thinking through these two main questions we need to address booster doses. Do we need them, and do they work? We can take these questions to think through using aspects of our evidence to recommendation framework. To answer, do we need them, we'll think through the public health problem of COVID and what information we have on the current vaccines. Then, do they work? We will think through the benefits and possible harms of booster doses of COVID vaccines. Next slide. So under the public health problem, we'll need to specifically address, is vaccine effectiveness, or VE, waning over time? Is VE reduced for the Delta variant? And does this data vary by subpopulation? Under benefits and harms, we'll need to address if booster doses of COVID vaccines are safe and immunogenic. Will booster doses of COVID vaccines reduce COVID incidence, hospitalization, and mortality? And do booster doses improve VE against the Delta variant? We'll walk through each of these questions in more detail, outlining data we'll be collecting to address these overall questions. Next slide. First, is VE waning over time? Specifically, we need to assess if VE at 6 to 8 months is similar to what was noted at 2 months after vaccination that ACIP reviewed at the time of the EUA. And how does this data vary by severity of disease? We may see that VE wanes for asymptomatic or mild disease, but remains high for severe disease, hospitalization, and death. And what data on waning VE would identify a need for booster doses of COVID vaccines? Next slide. So the next is VE reduced for the Delta variant. And again, how does this vary by severity of disease? And while the Delta variant is clearly what we're dealing with right now, how would this information on Delta variant impact VE for future variants? Next slide. And finally, for the public health problem, the final question for the public health problem, does this data vary by subpopulation? At previous ACIP meetings, we've discussed that boosters may be recommended for the entire population, or they could only be needed among specific subpopulations. Groups identified as needed close monitoring and additional data collection include residents of long-term care facilities, adults 65 years of age and over, and healthcare personnel. Next slide. For long-term care facility residents and older adults, we've already highlighted that these were vaccinated in the earlier phases of the COVID-19 vaccine rollout. In addition, this is a population that has needed special considerations for other vaccines, including additional boosters or higher dose vaccines. In addition, healthcare personnel were vaccinated in the early phase of the vaccine rollout. They will have continued exposure to SARS-CoV-2. And another point that was not mentioned at a previous meeting, but clearly could be an issue in the future, there could be a need for additional considerations for healthcare personnel to include the continuity of healthcare systems. We may have a very specific need to prevent asymptomatic or mild infections in healthcare personnel if there are COVID surges straining healthcare infrastructure. Next slide. So next, moving to the benefits and harms. We need to address if booster doses of COVID vaccines are safe and immunogenic. Assuring COVID vaccine safety has been a critical of the entire COVID vaccine program and will continue into this phase as well. We need to know if COVID vaccines provide a boost in neutralizing antibody response. And while we're likely to get this information, we also need to address how neutralizing antibodies correlate to clinical protection from COVID-19. Next slide. We need to evaluate if booster doses of COVID vaccines will reduce COVID incidence, hospitalization, and mortality. We're not likely to have long-term efficacy studies with booster doses, but need to think through other ways to address if booster doses will reduce COVID morbidity and mortality. Next slide. Then, do booster doses improve VE against the Delta variant and other variants of concern? Again, Delta is what we're focused on now, but it's unlikely to be the only variant we'll have to address in the future. What do we know about boosters and other known variants of concern, and how can this data inform VE for future variants? Next slide. So now highlighting the workgroup interpretation of these considerations and the framework around booster doses. First, for their thoughts around the public health problem. Right now, the largest public health impact will continue to be from individuals receiving the COVID vaccine primary series. We know that the vast majority of cases, especially cases requiring medical attention now, are in unvaccinated individuals. The best way to address the current surge we're experiencing is for individuals to receive the primary series that is currently recommended and available. Then, decisions for boosters need to focus on the prevention of severe disease, hospitalization, and death. And the work group strongly emphasized the importance of ensuring global vaccine availability. New variants could emerge from regions with low vaccine coverage and high community transmissions. One of the best ways to protect the population here from the next variant threat is to ensure that the remainder of the global population has access to a safe and effective COVID vaccine. Next slide. Next, the workgroup interpretation of the benefits and harms. Neutralizing antibody data will be important for booster dose discussions, but may not represent the entire immune response to COVID vaccines. We can't make decisions around boosters based solely on detectable neutralizing antibodies. The cellular immune response can be difficult to measure in a broad population, but is important in our ability to fight COVID. And commercial antibody testing is not authorized or recommended to evaluate post-vaccination immune response. Based on available data and the timing of vaccine rollout, the initial booster vaccine policy will be focused on the at-risk adult population. Adolescents are only just now receiving their primary series. The at-risk individuals we've highlighted that we'll focus on include adults 65 years of age and over, long-term care facility residents, and healthcare personnel. Next slide. So going back to our roadmap for booster doses, today we've discussed key considerations for decision-making. Next slide. The plan now is to have another ACIP meeting in the next several weeks where we'll fill in this framework and identify what data are available for decision making. Then, once we've evaluated the available data and have regulatory allowance for booster doses, we can address if ACIP recommends booster doses of COVID vaccines in any populations. Next slide. I do want to highlight that there will be some questions we may not have the amount of data desired as we move into these decisions. We may not have detailed information around how VE varies for each specific COVID vaccine in each specific subpopulation. We may not know VE for booster doses of COVID vaccines, especially in each subpopulation. And finally, we won't know how the need for booster doses of COVID vaccines evolve as the pandemic evolves. However, by continuing to present and discuss the available data at public ACIP meetings, we can highlight what we know and don't know, and how that information can inform possible future recommendations. Next slide. I want to thank the mighty team listed here that's helped with the many things our COVID ACIP team is working on that you see and don't see, as well as the Vaccine and Epi Task Force and Respiratory Viruses branch here at CDC. Next slide. So our questions posed to ACIP today is, does ACIP agree with the framework laid out to address booster dose recommendations and the workgroup interpretations? And are there other questions that would be important for ACIP to address? Thanks.
Thank you so much, Dr. Oliver. That was an excellent presentation as always, and a clear delineation of the issues at hand. I want to ask, are there any ACIP members who have any questions that they'd like to ask? Dr. Talbot.
I actually have two. I think one of the important things for us to define are how many, or to define the number of areas in the U.S. with low vaccination rates. Giving a third dose to people who are already willing to get a vaccine into mass may not overcome the large pockets of unvaccination. And so I think
Dr. Talbot? We can't hear you. Dr. Lee, can you hear us?
Comments and the questions. I'm hoping they can hear us, and then at the end we can capture all the comments and have a discussion about those.
Dr. Lee, just to give you an update, you're back.
Dr. Virginia Kane with the National Medical Association. Are we also looking at my concern for boosters related to chronic medical underlying conditions such as diabetes in our patients where they may be immunocompromised? And we know the durations of our vaccines based on your studies you just showed about 8 months. But does the Delta variant create any issues for the longevity of our immunity related to the effectiveness of this boost immunization? So I'm very concerned that it may be a different efficacy depending on race and the type of chronic underlying medical condition compared to our majority population. And I really emphasize this, that when you look at African Americans, Latino ex-populations, Native Americans, we are almost 3 times the rate of hospitalizations. Our death rates are over twice as great as our white counterparts. So I'm very concerned about making sure that we're doing those booster dose recommendations that's really required for our populations that may have a higher rate of some mild immunocompromise that doesn't merit the rank of being a transplant or a advanced treated HIV, but a significant populations of a lot of chronic medical conditions that can impact us.
Okay, thank you so much, Dr. Kane. There's a couple more questions in the chat. I see that our CDC colleagues are back on. May I ask if you were able to hear the questions or the comments, or if you missed them?
Hi, Dr. Lee, this is Dr. Oliver. Can you hear me?
We can, yes.
Okay, great. We dropped out through Dr. Talbot's questions, and then we heard what Dr. Kane said. So I don't know what was in between, but we're happy to follow up and have individuals on our team that were taking notes as well.
Okay, terrific. I think I'm just going to jump in for 1 second, this time as a member, and comment quickly about a couple of themes that I had heard, and also my own questions, which are, I think, better correlates of immunity are sorely needed. We actually all understand that. I think it would be really helpful to understand of the gaps in the data that are currently existing, you know, what's being pursued by the companies and or FDA as standards for immunity and or NIH to better understand it. You know, any information, I recognize that a lot of this won't necessarily sit within CDC, but it seems like we need that strong partnership to better define what the correlates of immunity are. The context of the unvaccinated can't be forgotten in the silo of this particular question, which I know you all recognize, but I think that was emphasized again. Individuals living in congregate living facilities, I'll just add that as a particular topic. And then this question about chronic medical conditions and race ethnicity, I think this reminds me of the conversations we had when we were talking about designing those clinical trials and ensuring that there are diverse populations included to demonstrate efficacy and safety, and just how important it is for us not to forget that continues to be important in the effectiveness and post-market safety phase, and that we need to continue to pay attention to any meaningful differences. And some of that is already in what you're doing with understanding risk by different conditions. But I think also just for us as ACIP to remind ourselves that we can't ever forget how important to continue that attention on ensuring that the benefits and the risks are, you know, for everyone. Okay, I'm going to pause there. Dr. Oliver, is there anything you want to respond to in the very short term before I move on to additional questions?
No, thank you. Just the noted and taking notes. I think we are aware of those gaps as well, and we'll hope to fill them in with future presentations, but taking notes. Thanks.
Thank you. Dr. Maldonado.
Yeah, thank you very much for laying out the framework for consideration in future policy decisions. But I want to make 2 points. The first is So we're well beyond a year now when these clinical trials started, and these many thousands of individuals submitted to really exciting opportunities, but also provided blood samples and lots of detailed follow-up. And I really think that the companies really owe it to the public health infrastructure of the U.S. and elsewhere to really find those data. I mean, it's been a year. We know that breakthrough cases happened. We know there's blood samples that were available. We should be able to identify at least some level of correlation between immune markers. Hello? Sorry. Anyway, correlation between immune markers and breakthrough cases versus not. I mean, that's not hard science. I mean, that's pretty straightforward. And I think the data should be there because the samples are there and the patients are there. So we really need to hold these groups accountable, given that many thousands of people volunteered, put blood in these biobanks, and they are available now. We should be seeing these data. So I really call on transparency on that. An immune correlate is critical at this point, and there's no reason why we should start to at least understand and know what we understand and what we don't. The second thing I want to point out is, again, relative to children, that let's not wait until we finish one set of studies before we start tacking on more studies. It takes more time to do that, and why not plan ahead with the children that we have now, like you have done with adults, so that we can enroll all the children we need up front and make sure that we do booster work with them too, if that is appropriate. But adding them on at the end is highly inefficient. It's not fair to the families, and it is really an obstacle for us to getting long-term data on children that we also need. So those are just two call to actions, if you will. Thanks.
Thank you, Dr. Maldonado. Dr. Zahn?
Yes, thank you, Dr. Lee. Just a comment is, I think it's going to be really important to be messaging appropriately about ACIP's deliberations. It seems like to me, as of today, officially, the ACIP is considering the need for a booster dose. But to my mind, from what I see from epidemiology in my community, I think around the country, I think we have very little evidence at this point that waning immunity, is a significant driver of burden disease right now. Right now, the overwhelming driver of disease, serious disease in particular, is people who are unvaccinated. And I think the CDC's, the ACIP's cadence of meetings for this, which is going to happen over several weeks, and obviously the FDA deliberations are going to be important as well, reflects, I think that reality. But I think that if epidemiologic data or those facts on the ground change, then ACIP and the FDA will change accordingly in terms of their assessment of the situation, to more promptly, provide guidance as needed. But I guess my point is that right now it seems like this conversation is anticipating the potential need over time to give a booster dose, as opposed to there's evidence that people need a booster dose right now, and the ACIP is just looking through the data. And I just think that that's an important distinction. That's going to be important to communicate that to the general public and to providers.
Thank you, Dr. Zahn. Are there any other questions or comments? Okay.
Dr. Lee, I don't see any other comments. Yeah. I know that this is the first of many discussions, and we do anticipate a part of the reason for us to have multiple meetings over the next several weeks is, as this data emerges, we wanted people to start thinking and be prepared to address it. So if you are ready, we can go ahead and close this meeting, or do you have any final comments?
Well, I just want to thank all of our presenters for leading these robust discussions on the topics, most recently of variants and boosters, but also for the vote on immunocompromised. I think it was a really productive meeting today. I'll look to my ACIP members to see if there are any last comments or suggestions that they might have. Okay. Well, hearing and seeing no additional hands raised, and given that we are running late, I will now be very happy to adjourn our meeting today and thank everyone for your participation and your engagement. Dr. Cohn, is there anything else?
That is it. This concludes the meeting after you officially conclude it, and we be on the lookout for information about a meeting on August 24th or any potential changes, and we appreciate everyone's time today.
Thank you. The meeting's now adjourned. Everyone have a great day. Take care.
Thanks.